all to this Sopicon 2023, which is the 20th annual conference of the Society of Pharmacovigilance India. The society, which is around 20 plus years old, and which mainly dwells with the issue of esteemed Director Ma'am, that she has accepted our invitation to be the chief guest for the event. Even though she has a busy schedule, she has to just travel to IIT Roorkee for another function and event. So thank you, ma'am, for accepting our invitation as a chief guest. And of course, we all know, ma'am, she is an inspiring figure for the institution as an academician par excellence, researcher of international repute, and invitation, and an administrator par excellence. So, of course, we all know how with each passing day she is enriching our institution and inspiring all of us. I would be sounding a bit poetic that her arrival has been just like a cool, gentle breeze from the Shivaliks, which is inspiring us every day. So, somebody who doesn't need an introduction, Professor Balram Bhargav, a great innovator, internationally acclaimed cardiologist, administrator, and a Padma Shri awardee. And all of us know that he was one of the architects of the country's response to the COVID-19 pandemic. So I think he's a household name. So we are delighted to have him here at the at our institute. We tried earlier also to invite him, but he was such a busy person all these years, fighting the COVID pandemic. So we are privileged and honored to have him here today with us. Our co-patron, Dean Academics, Professor Jaya Chaturvedi, is an inspiring and such a supportive person for all the faculty and students. I welcome ma'am and thank you for he is actively involved in running the society for a number of years. He is a surgical oncologist and an eminent surgical oncologist who has his own facility at Agra. And I thank him for taking out time and coming over to attend this conference. The Secretary General of the Society, Dr. Ziaur Rahman, a fellow of the National Academy, a veteran pharmacologist, and we are thankful. And he is the pivotal person who has brought this conference to our institute. Thank you for your visit. And I would also like to thank Dr. Puneet and specifically mention the organizing committee who have organized the event, Dr. Manisha, and all my departmental people. The theme of the conference is drug safety in an era of evidence-based medicine. And it does not, it's not something for the pharmacologists only to discuss. It concerns is concerned about drug safety and vaccine safety. So I think that this is an apt event where we can discuss all the aspects of drug safety. We have a galaxy of experts who are here to deliberate on various aspects and dimensions related to drug safety. And so I hope this event and these 2 days scientific program will be an enriching experience for all those delegates who are joining us physically and those who are joining us virtually. We have around 250 delegates who have registered, and around 100 of them are joining us virtually. So with these words, I welcome you all to this conference and wish you a pleasant stay in our beautiful campus. Thank you very much.
Thank you, sir. Since our chief guest, Professor Meenu Singh, Executive Director and CEO AIIMS Rishikesh, has to leave for a function at IIT Roorkee, these two words are interlinked. And for that, we have to understand a little bit what we mean by evidence-based medicine, which is actually turning clinical problems into research questions and then trying to access literature or evidence which is related. We need to audit how was the therapy which was applied based on randomized controlled trials or systematic reviews to the clinical practice and how it brought out the usefulness of that therapy. And actually the usefulness of the therapy is dependent on what is known as cost effectiveness, that is effect as well as the side effect. Now effect is something which is measured in terms of the effect which we get, that means for which the drug or the therapy was designed, whether it was hypertension or asthma, whether it led to control of hypertension in a better way, it produced a greater fall in blood pressure in those individuals. But along with that, we also have to see what were the side effects. Now, side effects is something which are studied in the randomized controlled trials, but sometimes these side effects are long-term. And most randomized controlled trials get terminated after a particular period of time, say 1 or 2 years. But sometimes the side effects may come up at a later date. And hence, it's very important that all these patients who enter randomized controlled trials as and that's why many times these trials turn into longitudinal studies as the cohorts get followed up. So for pharmacovigilance, I think that's something very important. And we know that adverse drug reporting is something which is extremely important in hospitals. And as we go for nursing or we go for medicine, as doctors, we just write medicines. But then what happens to the patient after that is something which is monitored by the nurses. So extremely important that the nurses should also be included in this pharmacovigilance activity. And along with that, nowadays, there are a number of programs which are computer-based, which can tell you about the drug interactions, and those should be consulted before we write medicines. And sometimes, even if a reaction has occurred or a drug interaction has occurred, one should also like to see what were the role of the other drugs which were being used in that particular patient. So it is actually not just drugs. It is not just drugs, it is also the patient which is important. And most patients, we know they handle drugs differently. We know that we are in this age of personalized medicine in which we find that even common drugs like anti-TB drugs, they behave differently in different individuals because that particular scenario. And that's again the role of RCTs to be done at a place where the drug has to be introduced ultimately. So that is about, that you can't absolutely generalize whatever has happened in the West to Indian scenario. So I think this is just to set the mood for this conference, which is going to be there for 2 days. I think yesterday there was a workshop also, and you all must have experienced a very good training in that. And I'm sure a very good interaction is going to take place among several experts. And we are going to come out with new thoughts and new visions for pharmacovigilance. With those words, thank you very much. Jai Hind. Jai Bharat.
Thank you, ma'am. Your speech is truly a beacon of light for all of us. With this, I would like to invite Professor Balram Bhargava to present a memento to Professor Meenu Singh. Continuing with the inaugural ceremony, may I now request Secretary General of Society of Pharmacovigilance of India, Professor Syed Ziaur Rahman, to deliver his address. Sir, kindly be invited to the podium.
Respected Chief Guest, Professor Meenu Singh, the Executive Director of AIIMS Rishikesh, our distinguished guest of honor, Padma Shri Professor Balram Bhargava sir, the guest of honor, another Professor Chaturvedi, Dean Academics, the President of the Society of Pharmacovigilance, Dr. Sandeep Agarwal, and the organizing chairperson, Professor Shailendra Handu, also the head of the Department of Pharmacology, Dr. Puneet Dhameja, the organizing secretary. Delegates, both attending online and offline, and the dear students. So at the very outset, I would like to thank, on behalf of the Society of Pharmacovigilance, to the organizing committee to organize such a beautiful conference, Sopicon 2023 at AIIMS Rishikesh. So we have come a long way to hold this another conference after the first conference, which was organized in 2002. And during COVID-19 and the lockdown period, we could all organize a few CMEs in collaboration and with the support of different institutes. Last year, the conference was fully organized with the online mode. So, ladies and gentlemen, the Society of Pharmacovigilance is basically a very vibrant society. It has around 490 members. It publishes Journal of Pharmacovigilance and Drug Safety for the last 19 years. This is a society which is also holds and invites very eminent personalities from the medical sciences. For the fellowship of Indian Pharmacovigilance, which is FPVI. So this year we didn't receive any application for the fellowship, but we received many applications for the Uppsala Prize, which is given to the best among the poster presentation category. So a lot will be shared by the organizing committee about this conference. But I would again like to thank all the participants attending this conference from all over India or world. Thanks once again, Dr. Shailendra Handu and Dr. Puneet for accepting our proposal and organizing this conference here at AIIMS Rishikesh. Thank you so much.
Thank you, sir. May I now request President, Society of Pharmacovigilance of India, Dr. Sandeep Agrawal, to deliver his presidential address. Welcome, sir.
Chief guest of this occasion, Professor Meenu Singh, Chief Patron as well as Director of AIIMS. Sopicon at AIIMS, Professor Handu, other distinguished delegates on the dais and off the dais, as well as distinguished presence of Professor K.C. Singhal, Professor D.K. Hajra, Dr. Mandal, Dr. Manoj Gupta, and others, distinguished faculty of AIIMS, students and delegates attending this Sopicon. It's real pleasure to have a Sopicon being organized in the ambience of an AIIMS. I recollect the initial days of pharmacovigilance being initiated with a single apex center being established in AIIMS New Delhi and a few satellite centers spread over the other parts of the country with a very, very minimal pharmacovigilance activity being observed in a country like India. There was a lot of brainstorming, a lot of efforts made from the Uppsala Monitoring Center as well as from the structure which was there at that time in India to initiate and promote the activity of pharmacovigilance. Years back, when we had an international workshop at Aligarh, which was later shifted to Delhi. And we have come a long way after that to today, when we are having these meetings, not only in academic campuses, but also there is a successful movement and effort which was initiated 20 years back to bring pharmacovigilance as a part of the curriculum in the MBBS. I know still there is a lot of reluctancy on the part of practicing medical fraternity as far as pharmacovigilance is concerned. Sometimes the question is asked, why I as a surgeon being there and what am I doing in this gathering? But believe me, as ma'am mentioned about evidence-based medicine,
a large chunk, or rather I would say a major part of evidence-based medicine is pharmacovigilance. Developing a drug, evaluating its efficacy, application in a large population, its benefits, unwanted effects, long-term safety, all these are measures which have to be part of the evidence-based medicine. Developed in West may not be safe in other parts of the world. So it makes it very, very important to make pharmacovigilance or bring it to the foremost of our medical practice. It has been unfortunate that pharmacovigilance was taken as a second fiddle and it was never considered by medical practitioners as part of the responsibility. I remember a paper which was presented during the Uppsala meeting, where a questionnaire was asked why there is reluctancy about reporting adverse drug reactions. And the excuse given by many of them was there is no incentive of reporting ADR. Thanks now with this digital world, now we have readily available platforms on which ADRs can be reported. Otherwise, I think 15, 20 years back, the ADRs were to be channeled via the National Monitoring Center. Things have become easier, faster, readily available to masses, and this has helped the cause of pharmacovigilance. I think we are now on a launching pad where we can take this movement of I thanks once again Professor Khandu for taking this initiative and organizing such a wonderful conference. And we hope that all who are attending this conference would be benefited with this meeting. Thank you once again for being here. Thank you.
Thank you, sir. It gives me immense pleasure to invite our esteemed dean. It gives me immense pleasure to invite our esteemed Dean Academics, Professor Jaya Chaturvedi ma'am, to address the gathering. With her extensive knowledge and experience in the field of obstetrics and gynecology, she has been a great support for the institution. And we are privileged to have her as a part of our academic community. I'm sure that her valuable insights and words of wisdom will inspire and motivate us all. I welcome ma'am.
Good morning. It's my pleasure to be here in this Sopicon, 20th con. Of honor, Padma Shri, Dr. Bhargav, Sopicon President, Sopicon Secretary, Dr. Agarwal and Dr. Rahman, our organizing chairperson, Dr. Handu, and organizing secretary, Dr. Puneet Dhamija. Department is organizing this pharmacovigilance conference, and pharmacovigilance is a very broad term. And this includes, we all know, detection of any adverse reaction. But for that, we should be aware of the adverse reactions occurring, interaction, drugs which are interacting with each other. So in India, what happens? There are so many pathies and patients are taking so many drugs all together, which are not coming in our notice also. So there is need to work on this, need of other. So many mixes are available in the market. Those are interacting with the drugs which we are prescribing to the patients. So all that is to be taken out from the patient. And even what I noticed that the pharmacological companies which are launching the new drugs, for the conference of 2 days, in which all the dignitaries who are present from all over the India, lot many teachers are here who contributed so many years of their our pharmacology department and all the delegates who came from all over the India. Thank you so much.
Thank you, ma'am, for your beautiful words. In today's inaugural ceremony, it is our honor to have Professor Balram Bhargava, an eminent cardiologist and Chief Cardiothoracic Center, AIIMS New Delhi, former Director General of ICMR and Secretary Department of Health Research, a Padma Shri awardee amongst us. As we gather here to discuss medication safety in an era of evidence-based medicine, his insights and vast expertise will be invaluable to us all. Once again, on behalf of the Society of Pharmacovigilance of India, I extend my warmest welcome to you, sir. May I please request, sir, to address the delegates.
So, honorable dignitaries of the dais, in the early 60s, 61, by the yellow card system, by the MHRA in the United Kingdom, later on in Salai University as well. And then the material vigilance, which was started by the John Ocean, which is the oration that we are going to talk about, how material vigilance and use of plastics and use of implants and class 3 devices, class 2 devices, and how plastics and other metals interact are so important, not only for drugs, vaccines, devices, diagnostics, but they are because in today's world where innovation is happening at every level, a lot of innovation is happening. We need to be very clear what is going to be useful for us, because as Mahatma Gandhi clearly said, that there is a very thin line between need and greed. And then Edison said that anything that does not sell, I will not invent. So there is a delicate balance in India where we have to maintain between Gandhian innovation and Edisonian innovation. And from that perspective, any newer innovation that happens and the deliberation that this meeting will be of tremendous value, not only to propagate this subject in society, but at the same time to the industry, as well as to all practicing physicians, nurses, and doctors. So I wish all the best, and I'm sure it'll be a grand success. All the best.
So thank you for your inspiring words. The esteemed dignitaries here on stage with us were extremely kind to accept our invitation and take out time from their busy schedules. Thus, we take this opportunity to present a token of gratitude to them. I would invite Professor Meenu Singh to kindly present a memento to Professor Balram Bhargava, sir. I would like to invite Professor Jaya Chaturvedi to present a memento to Dr. Sandeep Agarwal. I would like to invite Professor Puneet Thamija to present a memento to Dr. Syed Ziaur Rahman. As we proceed to the end of the inaugural ceremony, I request Dr. Puneet Thamija to deliver a vote of thanks.
Express our heartfelt gratitude to all those who have made this inaugural session a resounding success. Firstly, I would like to thank our esteemed guests for gracing us with their presence and inaugurating this event. Your support and encouragement are invaluable to us. I would like to extend my sincere thanks to our chief guest and patron, Professor Meenu Singh, guest of honor, Professor Balram Bhargav, Dean Academics, Dr. Jaya Chaturvedi, and Chairperson Society of Pharmacovigilance India, Dr. Sandeep Agarwal, and Secretary Society of Pharmacovigilance India, Professor Rahman, for sharing their expertise and insights with us today. Your presence has added immense value to the event. We would also like to express our gratitude to all the participants who have joined us from far and wide to share their experiences and their knowledge. Your active participation and engagement have made this session truly enriching. We also extend our thanks to our colleagues and staff who have worked tirelessly behind the scenes to ensure smooth functioning of this event. And but not the least, I would like to thank Professor Shailendra Handu for his constant support and guidance. Tone for a productive and enlightening activities in future. Thank you once again. Thank you all for your presence and your participation.
Thank you, sir. With this, we conclude the inaugural function of the conference. I thank all the dignitaries and delegates for gracing the occasion. Thank you all. We continue with the second session, which is the prestigious John Ossian oration. I welcome you all to the oration. I would like to invite our chairpersons for the oration, Professor K.C. Singhal. Professor K.C. Singhal earned his BSc from Aligarh Muslim University. He did MBBS in 1959 and MD in 1968 from King George Medical College, Lucknow. So pursued his PhD in 1976. As the chairman, Department of Pharmacology, Jawaharlal Nehru Medical College from 1990 to 1996, and then from 1999 to 2002. He was the founder vice chancellor of AIIMS University, Jaipur, India. He has made extensively and highly significant contributions in the field of pharmacology. He is one of the foremost pioneers in the field of Indian pharmacovigilance and has organized many scientific meets in the field of pharmacovigilance. He founded the Society of Pharmacovigilance of India, that is SOPI, in 1999. Sir has received numerous awards and orations, including B.C. Sharma Memorial Research Award of Indian Medical Association, S.S. Parmar Foundation Award of Indian Academy of Neurosciences, Major General S.L. Bhatia Oration Awards of Association of Physiologists and Pharmacologists of India, Colonel R.N. Chopra Oration Award of Indian Pharmacological Society, Platinum Jubilee Oration Award of Pharmacovigilance of India. He was awarded Distinguished Visiting Professor by University of Tunis in 2005. We are delighted by your presence, sir. Now I welcome our second chairperson of the session, Professor Vartika Saxena, Dean Research, AIIMS Rishikesh. Professor Vartika Saxena is Dean Research, AIIMS Rishikesh, Professor and HOD, Department of Community Medicine, and Advisor, Telemedicine Committee, AIIMS Rishikesh. She has over 24 years of wide-ranging professional experience in the field of public health. She has over 75 research publications and book chapters to her credit. She has worked with national and international agencies like USAID, World Bank, Future International for improving health status outreach and underprivileged communities. Professor Vartika Saxena served UNICEF as nutrition consultant for 3 years. I welcome you, ma'am. Now I invite Secretary General of Society of Pharmacovigilance,
Thank you so much. So we have John Orton oration, and I'm thankful to the chairperson, Dr. Vartika Saxena and Professor K.C. Singhal, and obviously, of course, the speaker, Professor Balram Bhargav. So it's my honor to briefly tell you about John Orton, on whom we have this oration. John Orton was basically the American scientist. He was born in 1924 and died in 2015 at the age of 91 years. He was a native of Philadelphia, and he received the BS in pharmacy at Temple University and both MS Pharmacy and PhD from the University of Maryland. He joined the University of Tennessee Health Science Center of College of Pharmacy in 1967 and established material science technology toxicological laboratories. And this is the turning point for his contribution. The labs reached a level of national and international prominence and helped establish new federal regulations on medical devices. So he started writing He served as president of the University of Tennessee Health Science Center, Faculty Senate, chairman of the Department of Molecular Biology, and from the same institution, he received the National Alumni Association Public Service Award. He was Dean College of Pharmacy and later on served till retirement as the Vice Chancellor of Research University of Tennessee. He was a regular visitor to India, contributed endowment fund to Indian Pharmacological founder of Sopicon. Because of his significant contribution to Indian science also, Professor Singhal once proposed to have an oration after him. Thus, this oration was started in 2002 and was delivered by eminent scientists of India and abroad, such as Dr. Ralph Edward, the former director of UMC Uppsala, and Dr. Mary Lindquist, again, former director of UMC, Dr. C.P. Thakur, former Minister of Health and Education, Dr. Rashid the former Director General of ICMR. Now I request Professor K.C. Singhal and Professor Saxena to welcome Professor Bhargav for the oration.
A very, very good morning to all of you. It is my honor and a moment of delight to introduce a true visionary in the field of medicine, Professor Balram Bhargav. His journey of medical education is started from MBBS from King George Medical College, Lucknow, followed by MD in medicine and DM in cardiology from the same institute. He has joined All India Institute of Medical Sciences, New Delhi after that, and rose to become internationally renowned cardiologist. He is currently serving as a chief of cardiothoracic center at AIIMS Delhi. He is an accomplished researcher with more than 500 research publications in peer-reviewed journal and is also editor-in-chief of British Medical Journal of Innovations. He is a medical educationist and an who has made significant contribution to the field of cardiology, and as a professor of cardiology at AIIMS New Delhi and as an executive director of Stanford Indian Biodesign Center, School of International Biodesign, he has demonstrated exceptional leadership and innovation qualities. Professor Bhargav has made significant contributions to the field of cardiology and played a pivotal role in the development and clinical evaluation of indigenous platinum iridium coil coronary stents. Dr. Bhargav has also established the Center of Excellence for Stem Cell Studies. He is also the founder of the Society for Less Investigative Medicine, that is SLIM. Currently, Dr. Bhargav is developing the chest compression device for sudden cardiac arrest patients, which is being funded by Wellcome Trust. He is also providing leadership for cardiac disease prevention, early detection and transport system for sick cardiac patients, which is leading to Mission Delhi. His work is truly inspirational and demonstrates his commitment to improve healthcare for all. He Health Research, Ministry of Health and Family Welfare, Government of India. Dr. Bhargav has expertise and leadership in the field of medicine, and it has been instrumental in shaping India's healthcare landscape. Under his leadership, ICMR played a critical role in responding to COVID-19 pandemic and mitigated its impact in India. On 13 June 2022, Dr. Bhargav launched ICMR National Hospital-Based Registry on venous thromboembolic disorder. His tireless efforts have helped India to become a global leader in healthcare research and innovations. Dr. Bhargav's contribution to the field of medicine have earned him several prestigious awards and fellowships, including Padma Shri Award by the Government of India in 2014, National Academy of Science Platinum Jubilee Award 2011, SN Post Centenary Award by the Indian National Science Congress, Tata Innovation Fellowship 2007 and 8. And also he has received Vaswick Award, Biomedical Technology Innovation. He is also a fellow of the Royal College of Physicians of Glasgow and Edinburgh, the American College of Cardiology, American Heart Association, the International Academy of Cardiovascular Sciences, truly innovator par excellence and inspiration to all. In recent years, he has been at the forefront of managing public health crisis also when all of us, we were facing COVID-19 pandemic. And he has been instrumental in shaping global practices through vaccine development, describing the role of plasma therapy. Sir has delivered over more than 40 orations across the globe with over 6 years of international experience in USA, Europe, Middle East, and he has brought a global perspective to his work. Ladies and gentlemen, please join me in welcoming this remarkable individual whose dedication to advancing healthcare has touched countless lives. Today, when India has provided more than 2 billion COVID vaccine dosage, I am a kind of architect of India's COVID vaccination program. I really invite him with a feeling of proud and privilege to have him here in the Institute of All India Medical Sciences Rishikesh. So let us welcome him with a good round of applause.
So, honorable chairpersons, friends, we have today the Professor John Ocean oration. We all know that John Ocean, I'll tell you briefly, I think has been told, but he was the father of material vigilance, pharmacologist, a toxicologist, a biomedical materials expert, and he established the US FDA guidelines and regulations for medical devices. So this was the work that he did in 1960-61, led to the establishment of these guidelines. And he was from the Temple University and the University. Can we see the slides?
लैपटॉप पर्सन दिखाओ
लैपटॉप पर्सन तो भी कह रहे वो पूरा ये लोगो भी आना चाहिए साथ में इससे ज्यादा नहीं जा रहा क्लोज इससे ज्यादा नहीं जा रहा भाई तो ये लास्ट में
We have sound, please. Hello.
Yeah. It's working now?
Yes.
Can everyone, yeah, okay. So coming back to Professor John Ocean, who was the father of material vigilance, a pharmacologist, a toxicologist, biomedical materials expert, how plastics and how metals and valve implants and, at that time, open heart surgery was being recognized, and very poor valves were being replaced, people had rheumatic heart disease, and those implants were going to be there for life inside the body. So his basic philosophy was, and I'll just read out one or two. Specialized packaging system for storage and delivery of medications. So he read that a proper program should be done to evaluate the toxigenic properties, to evaluate whether the agent itself or its chelated properties, or once the blood comes in contact with it, then the released materials, whether they are teratogenic, mutagenic, or carcinogenic. And therefore, he said that various tests that are employed, whether this is going to benefit or the risk. So that risk-benefit ratio was what he said should be established for every device. What is the life of a device? What is going to be the problem with the device? And what is the materials that are going to be harmful? So he published these papers, the classic papers in 1960 and 61, which later on led to the US FDA regulations for medical devices. And I think that is one of the greatest contribution that has happened, as has happened for pharmacovigilance, for drugs vigilance. This was material vigilance, which was established. And now we have other things that the topic of the oration, which is the India's COVID vaccine saga. And I think what was the role of the Indian Council for Medical Research? Now, if you all know that on the 31st of December, or rather the 30th of December, 2019, there was this deputy editor of ProMed, which is a program trawling internet chatterbox. From that internet chatter, they reported 4 cases from the Wuhan Public Health Commission report. There is certain pneumonia which is there, and suddenly 27 cases were reported. And then Marjorie Pollock issued her own appeal to ProMed Network. And within hours, because of artificial intelligence and because of the internet, the artificial intelligence system at Boston Children's Hospital issued an alert, which is the seriousness of 3 out of 5, that there is something happening. And 80,000 subscribers of ProMed were immediately, within a matter of seconds, across the world, were this problem, that there is some pneumonia. And this was 30th of December 2019. And after that, in 2020, how I got into this, I'm a cardiologist, that too an interventional cardiologist. And how big was the beast? What was the behavior of this virus? What was the biology of this virus? We all didn't know. What happened was that on 6th of January, or rather 7th of January, the Ministry of Health, Government of India held an urgent meeting that this virus has happened in China. What should we do? What should be the discussions? And on 26th of January, we had one patient. So I will, and this whole story is mentioned in this book, which I have written called Going Viral, through the AGs of the ICMR, which was, you want this? I think everyone can you hear me? Yeah, I think that's okay. So what is the ICMR? It's the Indian Council of Medical Research, which was also known as the Indian Research Fund Association, established one of the oldest scientific research bodies in the world, actually. Groundbreaking discoveries. Right from the 1918, the very inquiry was done by them during pre-independence. Then 1938, malaria survey was done, and Ronald Ross subsequently did work and got the Nobel Prize. Kala-Azar cycle was, again, by Leishmania Donovan, was documented while working at this organization, and he got the Nobel Prize. Then the domiciliary treatment for TB, the short-term treatment, the first oral polio vaccine trial, the low-calorie malnutrition and the protein energy malnutrition myth was bust by my predecessors at the ICMR. And then oral rehydration therapy in 1970 was established. And you know that Pradeep Mahanalabis was awarded with the Padma Bhushan this year for his discovery on oral rehydration therapy. India's first test tube baby, which was the second test tube baby in the world after Edinburgh, was done in India. Much of the work was done in Calcutta. And then double fortified salt in 1994 for iodine deficiency, hypothyroid. So this was the major work that was done in of COVID-19. This case was a medical student who traveled from, and this has been traveled from Wuhan to Hong Kong, Hong Kong to Calcutta, Calcutta to Bangalore, Bangalore to Cochin, and then by bus to his hometown. And this medical student developed fever and was diagnosed by the National Institute of Virology unit in Alappuzha in Kerala on the 27th of January as COVID-19. And that was the very first case of COVID-19 in India, and was reported to me at 10 in the night that this is, and I had to break this news to the government that yes, this virus has entered our country and we are also vulnerable to this virus. Before reporting, I said the sample should be sent to National Institute of Virology in Pune, which is the first PSL-4 laboratory in the world, in Southeast Asia region, established in 2010. It is a biosafety confirm the diagnosis and reported to the government, yes, this virus is definitely COVID-19. And we in India are vulnerable to this, and we need to take precautions. And all the contacts of this patient backwards, working backwards, right up to Calcutta, were screened and isolated, right from the bus ride from his hometown to Cochin, flight from Cochin to Bangalore to Calcutta. They were all isolated and identified, isolated at that point in time. So that was done through the help of ICMR and the Ministry of Health. And I was put into this because there was only one diagnostic laboratory in the country for COVID-19 at that point in time. And the cardiologists were asked to look after the virus problems. Now, what happened was that during the COVID pandemic, we used to have regular meetings. And we realized that COVID had reached our shores few months later compared to the Western population. There was havoc in the United Kingdom. Which did not work. And we realized this, so we got learnings from what was happening in the Western world. So we said that we need to impose some sort of a restriction in the country, whether it be by flights. And then the expert monitoring committee was formed by the cabinet secretary, which was meeting every day. We had shortage of diagnostics kits, we had shortage of PPEs, we had shortage of face masks, we had shortage of oxygen, all those things we realized, and there was a subgroup created for each one of them under the cabinet secretary at that point in time to look at them and try to find out solutions for the nation. Over and above the group of secretaries, there was a group of ministers which was constituted, and they were also meeting every week to decide what should be the next course of action. Like on a war footing, it was being done, and the leadership was monitoring everything day to day. So our COVID pandemic was that our leadership was serious from the response, which was based purely on science, and it was science driven with the presence of a strong leadership with excellent communication, taking all the states along, all the chief ministers of all the states along, and informing them, having meetings, VCs, etc. with them. So our philosophy was based on test, track, treat, and not herd immunity, which led to a large number of mortality in Sweden, United Kingdom, Spain. We did not embrace herd immunity at all. We believed in isolation at that point in time. So if I were to summarize what were the 10 COVID-19 highlights of the Indian Council of Medical Research, they were the following. Number one was the countrywide scaling up of the testing network from 1 laboratory to 3,000 laboratories in the country. Diagnostic kit self-sufficiency. I'm talking about February 2020. We didn't have diagnostic kits. We were asked by countries like China to purchase in a matter of hours. Otherwise, they would divert into some other country. We had to take decisions in a matter of minutes to buy those kits. So we decided that we will develop So that was an example of self-sufficiency. We did the nationwide sero survey, the largest sero survey in the world. 4 rounds of that survey. The first round was done in May. We'll talk a little bit about it. We did the validation and diagnostics and local manufacturers, indigenous vaccine development, which I will talk in more detail. The phase 3 from the virus isolation to phase 3, preclinical animal studies to international research, more than 300 research publications on COVID-19 with all Indian authors. That was my philosophy for them was very clear. Whatever work you have done, please document it and document it fast. Otherwise, and we were able to get 300 publications in top journals across the world. Treatment diagnostic guidelines, which we talked about, the social behavior research, stigma, vaccine hesitancy, innovative service delivery by drones, and I'll talk that. So coming back to the BSL-4 laboratory and the diagnostic kits. So this was the first BSL-4 laboratory in Southeast Asia, which was developed by the first in India, and my predecessors have set this lab up. And the second lab was the Wuhan lab, which I mentioned, which was developed. Smallpox virus was destroyed in India, but one sample is remaining in Russia and one sample is remaining in the United States. So they still have the smallpox virus. There are several laboratories across the world which are looking at viruses, and the repositories are there. So February, we had this group of secretaries, and on 9th of March, we were the 5th country in the world to isolate the virus. We tried to get the virus from the WHO. Every country was wanting the virus. We were not, there was not much communication and supply to different countries. So we were able to, there was a group of visitors from tourists from, I think it was from Italy, who were visiting Agra and Rajasthan. And they were admitted with COVID-19, 11 tourists, and we were able to get samples from them through our ICMR network. We immediately got samples every day. And from that, we were able to culture the virus and isolate the virus. And on 9th of March, we were able to isolate the virus. We were the first country in terms of testing. February, we had only the RT-PCR tests. And as I mentioned, we were approached by different countries that these are limited number of kits available. WHO was able to supply us of 10,000 kits at that point in time for a country of 1.4 billion. It was just a drop in the ocean. It was difficult. So at that time, we said we have to be innovative. And we said that we repurpose our TrueNat machine. The TrueNat machine is an indigenous molecular diagnostic portable machine for tuberculosis testing, which was developed by the Indian Institute of Science and funded by the Department of Biotechnology, CSIR, and investigated, and WHO pre-qualification and multicentric trials, multinational trials were done by ICMR to get it a WHO pre-qualification for tuberculosis in 2017, 2018. And this machine for tuberculosis diagnosis, 8,000 of such machines were already there in different parts of the country. So immediately in February, March, we repurposed because we had already repurposed it for Nipah virus and 8,000 of these machines were available for COVID-19 testing. But the problem was that this can test a very small number of samples in a day. At one time, 4 samples, and then some machines had 16 samples. So this TrueNat machine was upgraded in April of 2020. And then in June, when we had the first wave in New Delhi, June of 2020, first wave in Delhi, we said that we'd use the antigen kits. And this, Korea was the first country to use antigen kits. And we said that we would start using it. And then Indian, can we have the slides? What is that? It's coming up. So they are there anyway. So then we used the antigen kit for the first time in India and in June. And on September, by September, there was testing available and we were exporting kits by June, July. The TrueNat molecular diagnostic kit that we were using was first by India. The United Kingdom developed another kit called DNA Nudge, which was available in September, much later than what we had started. Tested, I think much more now. This is slightly dated slide. And the cost of one RT-PCR test was $2 per kit, and the rapid antigen kit was $1 per, compared to $200 outside in many parts of the world. And much of the labs 39% of the labs were working on one shift, and 32% of the labs across the country were working 3 shifts. All the data from testing was available at ICMR, was being sent to ICMR on a daily basis, and that was available as and for analysis later on. So this is the upscaling of the TrueNat, which was done across the country. And on June 9th, 2020, we also had discussion in ministry and said that we will ask all the medical colleges to set up a PSL2 laboratory. Otherwise, they would be they had to if they have to keep their registration alive. So we were using the carrot and stick at the same time, and 580 or 30 odd medical colleges were able to start that immediately, very fast. And then comes the story of 10 restrictions. And then I was requested by the cabinet secretary that please make a document on a 1 page that what do you want should be done for the COVID pandemic in March, on 10th of March. I said, we had some consultation and we decided, and I wrote 2 lines on that 1 page. Impose travel restrictions for all international travel, number 1. And number 2, impose lockdown so that we can develop our health infrastructure and repurpose it and improve it during the time, because then there will be less movement. And I think this was on, I think, 18th of March, I was requested to send before the leadership. I took 5 slides and presented that this is a problem and we need to have this. We belong to a generation of people who have dealt with Jai Jawan, Jai Kisan and food shortages in the 60s and the PL 480 program, Colombo plan. So we will be able to manage without food. We will manage. And we told this to the leadership, and the next and during the lockdown, the ICMR became the nerve center for the testing, for the kits, for guidance, for policies. We had the IB sitting there, we had the research analysis wing, we had the Ministry of Civil Aviation sitting there, we had Indian Railways, we had Indian Air Force. We have this headquarters in New Delhi, where we were providing, we had about 40 scientists from 27 institutes, consisting of epidemiologists, pharmacologists, microbiologists who were called, and they were stationed in a lockdown at the ICMR guest house, the Asian Games Village, in the 40 rooms there, and they were working at the ICMR headquarters continuously from the morning till 12 in the night, guiding at every level. And I think kudos to them for working so hard at that point in time. And this during the lockdown, we had 4 phases of that. We had special flights commissioned for taking even 1 PPE kit to 1 small village by helicopter, and that was all coordinated through at regular meetings on PPEs, how India's textiles, how should we be self-sufficient enough. That happened very rapidly, a whole of government approach, where we were able to, within a matter of weeks, become self-sufficient and also start exporting to many parts of the world. So now the lockdown, because of the leadership, the lockdown was so effective that it was a Buddha's middle path, I would say. It was not like the draconian lockdown that we had seen in some parts of the world, or the liberal lockdown that we had seen in other parts of the world where no one listened to the lockdown, and people were all the time. So we got valuable time for to prepare for the worst, which was yet to come. We were able to set up PPE kits. We were able to set up masks. We were able to set up makeshift hospitals. We were able to set up quarantine centers. The ITBP, the Ministry of Defense, Hindon Air Force Base, Jaisalmer, Jodhpur. We developed all kinds of quarantine facilities, which were blankets and, you know, from people who were stranded in the Princess ship in Japan, from Italy, because there was a huge big problem there. And more importantly, what we learned from the lockdown was that we took the knowledge from different parts of the world and assimilated it for making and tweaked it relevant for India. Now, another small story I would like to tell was during the lockdown, February 2020, again, just before the lockdown, we had about 6,000 of our Shia pilgrims who were stranded in Iran. And we were asked that we have to get them back immediately. Then there was a discussion, how do we get them back without testing them? So again, ICMR is the testing laboratory for the country suddenly. So why not ask ICMR to set up a laboratory in Iran? Within 24 hours, we were given strict instructions that set up a laboratory in Iran to test those pilgrims and get them back. Passports were issued, equipment was gathered, and guidelines between the health secretary and myself every day, and on the bottom writing to all principal secretaries of all states and union territories, to all chief secretaries of all states and union territories. And before 12 p.m., this guideline would go to them. And next morning, the action would start. It was like a well-oiled machinery. And I think kudos to the bureaucracy. As medical professionals, we do not realize how the command system works in the bureaucracy. And that was fascinating, how we were able to leverage that. Similarly, the passport was issued within, and the visa and the tickets and the scientists left within 24 hours with all the equipment, with special flight, and they were able to set up the laboratory. Now, how to set up the laboratory in Iran? They had shortage of testing kits. They had people dying there. You can't set it up in the public there. So it was set up in the basement of the Indian embassy in Iran. And we tested those people, and all those who were negative were flown back immediately by special flights of the Indian Air Force and the Iranian Airlines. And the rest were kept there in quarantine for some. And at Jodhpur and many others, I don't even remember now, again with ITBP, Defense and the DGA, FMS. So it was a full of government machinery which worked like absolute magic, and how we were able to get these people back. Now, if we look at before the vaccine, what were the treatments available for COVID-19? Well, only 3 treatments are of significance which the world contributed. By science, number 1 was the use of steroids, which was done by the recovery trial by the United Kingdom. And they demonstrated that steroids are working and they can be given. The second was the use of remdesivir, that it reduces the hospital stay by the WHO. And we were also participant to that multicentric trial. And that demonstrated that the days of hospitalization was reduced by remdesivir. So United States contributed to the remdesivir trial through WHO. And the recovery trial was contributed by and answered by that steroids are working. By a randomized trial, clearly showing that convalescent plasma is not working. This trial was done during lockdown by VC. We had democratized research. We had taken district hospitals. They were doing this trial, a trial for the very first time, and we guided them on a daily basis by getting all the ethical approvals. 39 public-private hospitals and 464 patients were randomized to convalescent plasma and placebo, and we clearly demonstrated that this is not working. The registry of the Mayo Clinic of 100,000 people was saying that possibly it is working. This was clearly a final nail in the coffin that convalescent plasma is not working. It was established by ICMR, and this was published in the BMJ with 2 editorials on it, how India democratized research and how research was done by people who had never done research before, but guided by what we see, and we were able to show that. So these were the 3 pharmacological contributions: steroids working, convalescent plasma not working, remdesivir plus minus reduces the hospitalization. Scientific literature. Now, surveys and epidemiological studies. So during the lockdown, we had certain pharmaceutical agencies like Cadila and others who were going by car from Ahmedabad to Pune. They took the virus and we raised antibodies, and we were able to develop the ELISA kit for diagnosis. Within a matter of few weeks, this ELISA kit was done all during the lockdown. People traveling by car from Ahmedabad to Pune and at the NIV laboratory, and also the laboratory in Cadila and other laboratories in Gujarat. And this was the first indigenous kit called COVID Kavach ELISA, which was used for the largest sero survey done ever in mankind, 29,000 patients, which clearly demonstrated that May, June of 2020, that prevalence was only 0.7%. 99.3% of our population was still vulnerable for COVID-19, and therefore we need to observe all the quarantine measures and all the isolation measures that have to be done. So this then we did the second top journals: Lancet Global Health, International Journal of Infectious Disease, Indian Journal of Medical Research. Now coming to the vaccine. Now, we had isolated, as I mentioned, the virus on the 9th of March. We had an MOU, we had an expression of interest and an MOU, and then we were approached by Bharat Biotech that they will be able to develop the vaccine. Around the 30th of April, we were able to give them the virus, and they were able to give us the vaccine. Now, 30th of March, we were able to give them the virus. I have the agreement. And then we were able to get the vaccine in the first week of May. One candidate vaccine was given by Bharat Biotech in the first week of May. In the middle of, we had got the vaccine, we did testing on, and this collaboration was based on trust, transparency, timeliness, and mutual respect. And we realized that the time was demanding, and it was very essential to develop this. We'll be happy to do their studies in India, in country supply and in-country validation. We also, at that point, they were talking about human challenge studies to be done, which we did not allow at that point in time with them, that we will not allow giving the virus. We do not know how deadly the virus is, so we will not be able to do the human challenge studies. We were approached by Oxford for the same reason, definitely not. They said that we will do an international study on human challenge study, and they will be citizens of which country? So they said we'll take from different countries and put them on a ship and do human challenge study on a ship. So they will not belong to any country at that point in time or any land. So they will be on water. But that plan did not happen, and human challenge studies were not done. And we were against it from the ICMR, and we said we will not participate. So the first route was to get the international vaccines for technology transfer, to do the bridging studies and augmentation for global. And at that time, Serum Institute was working with Oxford, and they were also approved before Oxford had given it to AstraZeneca. They were in talks with us to collaborate with Oxford. They were we said that we will develop our own technology, and own technology was to develop our own vaccine. And as I mentioned, Bharat Biotech was the one which we were had vaccine candidate by May. Middle of May, the leadership took a meeting on vaccines of 2020, which vaccines are being developed by which institutes in the country. And I had not told anyone that we are developing this vaccine at the time because it was very preliminary. So when we had the meeting of the leadership, all the science agencies presented that they are working with University of Minnesota, with University of Washington, with University of Wisconsin, University of Madison, and we'll develop that vaccine, we'll develop this vaccine. At the end of the presentation, I raised my hand. I was asked by the leadership, yes, Bhargav, what do you want to say? I said, sir, हम लोग एक देसी वैक्सीन बनाने की कोशिश कर रहे हैं। भारत बायोटेक के साथ हम लोगों ने वायरस दिया है, कोशिश कर रहे हैं, वो स्टैंडर्ड टेक्निक से किल्ड वायरस टेक्निक की वैक्सीन है, कोशिश कर रहे हैं और यदि कामयाब होगी तो हम आपको बताते रहेंगे। उनका करिए, आगे करिए। And after that, developed this vaccine. The vaccine was candidate was there. We did the preclinical studies again at SMR on several institutes, testing the safety on small animals, safety, immunity, and the dosage. And we published that because we had a new adjuvant for this vaccine. These papers were published in iScience with a cover story regarding this vaccine, that this is a new adjuvant that has been used for the first time in the world. By an Indian inventor in the US, we had got that the adjuvant. The vaccine was developed by Bharat Biotech. We had given them the virus. It was again a full private-public partnership. We developed, did the small animal studies. Once we were able to establish the safety, immunity, and dosage, I hope I'm in time. We have another 10 minutes or so. Yeah. No. So then once we were able to identify the safety and immunity and the dosage of the vaccine, we had to do large animal studies. Now, large animal studies is another huge big story because monkeys are not being bred in India for a large number of years because of animal activists in the country. Now, how to capture monkeys from the wild? We got within again, government moves like this if it wants to move. Within 24 hours, we got permission from the environment, forests, and everyone that yes, you can capture 24 monkeys, and that will be taken. Those monkeys can be used for testing, and we got a team, assembled a team, and the team could not capture the monkeys in the cities because there was lockdown. And there was no food available. The monkeys had gone to the forest. So we had to go to the forest to capture those monkeys. Now, to capture those monkeys from Pune, went to Maharashtra border, Telangana border, Karnataka border. And within a matter of a week, we were able to capture 24 monkeys, caught those monkeys and took them to the biosafety level 4 facility where we have air-conditioned cages for monkeys in that facility, which is heavily security guarded. You cannot enter the BSL-4 laboratory in Pune without security and no normal. There is negative pressure because the people who are working on the virus need to work in negative pressure suits. The monkeys, we had to test whether these monkeys are healthy. So how do we test whether the monkeys are healthy? So we had to buy an X-ray machine. At that point in time, the cabinet and had issued an order that so certain purchases before 31st of May can be made without all the tendering process. So we were able to leverage those finance use a buy an X-ray machine in 24 hours and screen those monkeys, get all their blood tests done, and then put them in air-conditioned cages and show that they are. So how to do the monkey trial? The monkeys have been captured, they are in the air-conditioned cages. How do we do the trial? We gave them the vaccine. We gave them the vaccine, and now we have to challenge them with the virus. Now, how do you challenge them with the virus? You have to anesthetize the monkey, you have to do a bronchoscopy of the monkey, and give the virus in third generation of the bronchi, release the virus inside the lungs, and then do a bronchoalveolar lavage every day in anesthetized monkeys for the next 7 to 14 days. At the headquarters, sent him by a special IAF flight to Pune. We talked to the army chief and he asked the CTC Pune to arrange one pulmonologist. This is all during the lockdown. No one is moving in the cities. We pushed past those people. They were again locked in the NIV Pune guest house, National Pune guest house, for full 1 month. These two pulmonologists and their teams were locked there. They were doing the animal studies in the month of June, May, June, in those monkeys, which were captured and proven healthy by records. And Scoopy every day given the virus and then bronchoalveolar lavage for 14 days. And at 14 days, what we found that the virus had not grown. So that was the turning point where we realized that our mission is successfully accomplished and we can go to humans with this vaccine. These results we had in the month of June. We had these results. Phase 3, and then WHO pre-qualification, and the EU qualification. US FDA was in process, and the Canadian FDA approved it, and we were marketing this vaccine, or marketing rather giving it this vaccine. Now, this monkey trial had to be published. So we sent the paper to Nature. And during this time when we were doing the monkey trials, I had received several threatening letters and phone calls from agencies that we are told that you're going to capture monkeys. And I told them I had already captured the monkeys. I told them, no, I am not going to capture monkeys. So I am not going to capture those monkeys. Anyway, but we have done some work which we are sending to Nature. They came to know that we are sending the work to Nature. They wrote to the journal that these are monkeys not from a breeding facility, and they cannot be. This paper should not be published. India working against it. We send the health certificate of each and every monkey to the journal. And interesting story I want to further add. The Oxford vaccine, or the with the monkeys imported from China. So China is the largest exporter of monkeys and now is the largest importer of monkeys from Sri Lanka. You must have read about that. Because the Sri Lankan economy is in bad state, so they are exporting about 1 million monkeys to China because they have to do testing of safety, pharmacovigilance of drugs, cosmetics, vaccines, all being done in China. Each monkey used to cost about $500. Now, after the Ukraine war, each monkey costs about $4,000. Because China has stopped exporting those monkeys to America, and it's $4,000. India During this COVID-19 pandemic, we were able to set up a huge breeding facility, which is called the National Animal Research Facility in Hyderabad in the Genome Valley. That absolutely the best in Southeast Asia. And we also have a breeding facility near Bombay, which was initially funded by NIH in 2004-05, was stalled, nothing was happening, that has been reactivated, and that is also done. So that is the monkey story, which is. And then we did studies for CoV-D and the first world DNA vaccine, which was developed by Canada. We had done all the clinical trials for them. We said that they are not, should not be used in children. They had intended them to be used for children, but when ICMR told no, not ministry listened to us, and they were not used for children. And then we did the first studies for Alpha, Beta, Delta, and Omicron, various comparisons with Covaxin and Covishield. And the Covaxin phase 1, phase 2 was done. And the new clinical trial rules of 2019, before COVID pandemic, said that if, I'll just come to that anyway, we'll come to that. So this was in 2020, March 9th, the virus was phase 2 completed by December 16th, the first vaccination happened in the world, in the Western world. 3rd of January, the DCGI gave approval for the Indian vaccines, and 16th of January, 1 month later than the rest of the world, we were able to give vaccines. And 3rd of March next year, the leadership took the vaccine, and then the Indian vaccine was exported to more than 98 countries across the world. A stamp was released for this vaccine, postal stamp, and it clearly established that India is a pharmacy of the world, but now a vaccine superpower, wherein Indian vaccines were being manufactured. 60% of the childhood vaccines through the UN and WHO systems were being exported from India in the past. But here we went with Covaxin, we've proved that we could manufacture vaccines from start to finish, purely indigenous, developed in India, by India, for India, and for the world. And this was a success story, which clearly established that private-public partnership should be scaled up, not only in healthcare, but in other areas. We had this Rajkumari Amrit Kaur receiving a box from the High Commissioner of Canada. And in this box, after the Second World War, is a box of anyone? Is a box of penicillin injections. Penicillin was the first antibiotic developed. Canada contributed a box at that point in time, that this is a gift from Canada to India in 1947. And in 2021, we were able to gift the Indian vaccine to Canada at that point in time. So that was reversed because it was a critical and timely government support, right from funding to preclinical studies and a private-public partnership, to clinical studies, to laboratory studies, to epidemiological studies, to rolling regulatory review by the drug controller, advanced purchase orders, at-risk manufacturing, raw material import, and expedited batch testing and release. And batch testing facilities were scaled up, not only from Kasauli, but to Delhi NIB, to institutes of the trial rules, which I was mentioning, that these were approved in 2019, that when there is a life-threatening or a serious disease condition or rare diseases, or drugs that are intended to be used is in unmet medical need, then phase 2 is good enough to give approval in an emergency. And we leveraged this which was criticized by a lot of activists, was criticized by a lot of people who were not in the game, that this is and various competitors of the within the country were criticized ICMR and the Ministry of Health and the Government of India for leveraging the phase 2 for approval, but we did not see any serious problems with that. Now, coming back again, I'll take you back to March before the lockdown. On 18th of March, we constituted a committee which was called the National Task Force for COVID-19, which I requested the Health Secretary to be my co-chair, and requested the Planning Commission chairman to be the chair of that committee. This had 43 to 45 specialists of virology, epidemiology, pharmacology, microbiology, who were discussing every day. Different new drug that came was discussed. Should it come to India or not come to India? Should we develop it in India? Should our Indian manufacturers go for this or not? And therefore, we were able to not let a large number of unnecessary drugs or treatments go into our system, whether it be Western vaccines, which were having, which were very expensive and had several indemnity and other issues, which we were able to stall for many years, for many months, and certain drugs which were not going to be effective in the public health system of India, with things like molnupiravir, 2DG, Coronil. So we were able to stop a large number of those drugs and show that they're not working. By our advisories, and in our advisories, we did not include those. And this task force was informed to the Supreme Court of India on the 18th of March 2020 that this is the national task force. This will be guiding it, and that issued the various advisories and management protocols, which we have all seen across in different languages. Now, research publications, we had 6 issues. These are 5 and 1 more issue, 6 issues of IG. On epidemiology, on modeling, on pharmacology, on vaccines and animal studies were all published with not a single Western author as part of these 300 papers. So that clearly showed that we can do it in India together if we work together. And the impact factor of the Indian Journal of Medical Research rose to 6 from 2. It rose to 6 after the COVID pandemic. And we had we had other issues because there were systematic reviews, meta-analysis, network meta-analysis, living guidelines. We had to take all these drugs like baricitinib and roxutinib and sanilumab and tocilizumab and various other drugs, molnupiravir. We had to weigh the evidence whether it will be useful in the public health system for India rather than just entering without any regulation. And we issued various guidelines for communication, for infodemic management, for community management. We had clearly said that masks are a must, and masks will probably be the last not vaccine. And from the national database of COVID and the ICMR testing database of 94 crore 47 lakh individuals, partially vaccinated, fully vaccinated, and unvaccinated, we clearly demonstrated that 92% of the deaths during the Omicron wave in January of 2021 were unvaccinated people. So we clearly demonstrated that vaccine prevents death. And this was because of the 28,000 cold chain points. We have been running the universal immunization program through the Ministry of Health for the last 60 years, and one of the largest programs in the world, which has been with 2.3 million ASHA workers and millions of doctors and nurses. Out of these, 350,000 vaccination centers were public centers and 28,000 were private centers. So just 5% or 10% were from the privates. And India became a vaccine superpower.
with the IT prowess, we were able to develop the CoWIN app, which was for appointment scheduling and digital QR certificates. Many every citizen of India who participated phenomenally as self-help groups and local government. I think the Indian population were most disciplined as far as the COVID pandemic was compared to many nations in the world. So during the Omicron wave, we were much better than Russia, United Kingdom, Brazil, USA, Canada. If you look on the left side, in terms of the number of cases, in terms of the number of deaths, are much lower. And we know that the vaccination reduced the case fatality rate. As the vaccination went up, the case fatality rate went down. Now, one more point, interesting point, was when I joined the Indian Council of Medical Research in 2018, in March, April, the very next month, there was the outbreak of Nipah virus, which has about 80 to 90% mortality. So we didn't have a BSL-3 facility in the interiors of Kerala. So we said we should develop mobile BSL-3 laboratory. We approached the WHO. They told us a lot of stories. To remote areas, but we don't have airports in remote areas. And, so from that perspective, we said we'll develop our own BSL-3 mobile laboratory. The person who developed the BSL-4 laboratory in 2011 at ICMR, the first in Southeast Asia, he developed the mobile BSL-3 laboratory. This is state-of-the-art on a Mercedes-Benz chassis from Chennai and fully steel. If you go inside, negative pressure, there is a shower, there is absolutely like Apollo 11 inside, like with all computerized, if you look at it. So this mobile BSL-3 laboratory is parked at Pune. It parked at Gorakhpur, where we had the Japanese encephalitis virus. So when we had the Southeast Asia regional meeting in Paro in Bhutan, this mobile BSL-3 laboratory was demonstrated to all the health ministers of the Southeast Asia region and promised that a gift will be given from India as one of these laboratories after supplying in many places in India to each of these nations as part of soft power of the nation, and all the health ministers of all the Southeast Asia region. Then we had, might have read in today's newspaper also, this iDrone project is the ICMR's drone response and outreach in the Northeast, which was a unique, replicable, sustainable program wherein we had some drones. We tested them in the airport, which is at the IIT Kanpur. So IIT Kanpur has an airstrip. And as a student, you can also train as a private pilot license, and was established by the Indo-US collaboration at that point in time. So we used that airstrip to test the drones and the temperatures and the capability. And then we had an expression of interest. We were approached by 3 companies, and one of them, we took them with our scientists to Nagaland, to Mizoram, to Manipur, and we were able to take the vaccines with the help of the state headquarters, Drug Controller General, Ministry of Civil Aviation, the ICMR, University of Information, Expert Ethics Committee, and the airport. Was giving approval in 24 hours. Ethics committee approval in 24 hours for projects. They had to do it in 24 hours. And that was, I think, how we were able to test and get various products tested. So this clearly was demonstrated, was replicable, and we had various sorties independent showed the sustainability in Andaman Nicobar, Assam, and we were able to do several sorties in these states, clearly demonstrating land to land, hill to valley, lowland to highland, also from within the big lake. There is the Loktak Lake in Manipur, which is the largest freshwater lake in Asia again. In the middle of that lake, there is a small island which has a population of about 4,000 people. And in that island, there is a primary health center. So from Bishnupur, you travel by 3 hours by road, then 2 hours by boat, and then 3 hours on foot to reach that primary health center. So from Bishnupur, we send the vaccines to that primary health center in transporting blood from Lady Harding Medical College to the Government Institute in Noida, which would have taken several hours. Matter of, we did a feasibility trial, just came out in the paper today, where we were able to, from the same project, we were able to demonstrate how this vaccines. So this vaccine is 4 to 8 degrees. So a -70 vaccine cannot be delivered. Pfizer, Moderna, all. So here we have cool packs, and we were able to demonstrate first time in the world vaccines were transmitted by drones and was delivered. And we had automatic release mechanisms. One didn't have to go. The drone would fly off after releasing. And you can see how it was released. And I think that is very useful for Uttarakhand region, for blood samples, for other things, and could be leveraged in a big way. This is this little cartoon, which is showing the virus that he has gone to a very safe place on the Loktak Island or someplace. And he says the vaccine cannot reach me here. But we have the drone. We lost about 28 of our colleagues from ICMR, technicians, nurses, technicians, scientists, and people. We remember them and pay homage to them. So I thank you for your attention. For attention is the rarest and the purest form of generosity that you have done on me. I'm grateful to you for that. One more slide. This whole story is being made in a film called The Vaccine War with Anupam Kher as Cabinet Secretary and Nana Patekar as Director General ICMR. And this movie has already been made, is being edited now and should be available by Independence Day. So thank you so much for your attention.
I express my heartfelt thank you for an insightful and inspiring oration. Your ability to communicate complex journey of COVID-19 vaccination. So,
yeah.
Talk on an issue like COVID than Professor Balram Bhargava. He started the entire journey of COVID from its inception to creating infection in human beings, causing havoc all over the world, including our country, causing loss of life of thousands of people. But at the same time, he has explained very well that how he, as a person, as a layman, as a scientist, as an administrator, and as a planner, in the entire team, worked so well that India has escaped the havoc which has prevailed over other countries. So I congratulate him and thank him. Professor John Otian, in his name, this oration is a great friend of India and especially Indian science. He had visited about 16 times in various conferences, meetings to India, and he is always my guest. With his initiative, with his inspiration, we started the Society of Pharmacovigilance India. We had other people directly involved, like Dr. Sandeep Agrawal, Dr. R.K. Goel, Vice Chancellor of RIPSAR, Dr. Govind Mohan was Professor of Pharmacology at Agra, started this Society of Pharmacovigilance. We were experiencing the lack of knowledge in the physicians community with regard to adverse drug reactions. And this was essential that we should set up a program so that we could do something. We have tried our best in last more than 20 years to propagate the message with the collaboration of Uppsala Monitoring Center and with our friends in India and United States and other countries. John Otian was Vice Chancellor at University of Tennessee. I had a chance to visit that university twice as visiting professor. He was a great and respected person in the city of Memphis. In the entire community of academicians, as well as the Black community. Professor Bhargav is of a different nature. He is my Guru Bhai. His father, Professor K.P. Bhargav, who was at King George's Medical College, was my teacher at undergraduate level, at the postgraduate level. He is guide of my thesis of MD and my examiner also. So I owe great to his father for whatever I am is because of him. I was associated with him in many other ways, including when he was president of the Diabetic Society, I was the secretary of Diabetic Society at KGMC, and so many other ways. So, Professor Balram Bhargav, I think society has proposed him to give this oration, and I think he couldn't have been a better person. We couldn't have a better person to give this oration. I thank him again and thank you very much.
Thank you, sir. I would request Dean Academics, Professor Jaya Chaturvedi, to kindly present mementos to the chairpersons. I would once again express my gratitude on behalf of the organizing committee to Professor Balram Bhargava for being the guest of honor and a distinguished orator today. With that, we conclude the John Ossian Oration 2023. I invite you all for the high tea at level 2 of this auditorium. We will resume the session at 12 p.m.
session of the 20th Annual Conference of patient safety in an era of evidence-based medicine. I am confident that the insights and discussions that will take place during these sessions will be invaluable in furthering our collective goal. Once again, welcome to the session, and I wish you all a productive and an insightful experience.
We're all set to begin the first session on pharmacovigilance, an overview. It gives me immense pleasure to welcome Dr. Anand Srinivasan, Additional Professor, AIIMS Bhubaneswar, and Dr. Jayakaran Charan, Associate Professor, as chairpersons for the first session of the 20th Sopicon 2023. We begin our first talk with an introduction to pharmacovigilance, global and Indian scenario. May I now request chairpersons to preside over this session. Person to introduce the speaker.
नहीं मुझे सच में नहीं पता है चेक नहीं क्या करें चलो ना सफाई चाहिए अपने एग्जाम
Very good day to all. Welcome to Sopicon 2023. And the first session on pharmacovigilance will be taken by Dr. Manisha Bist. She is additional professor in the Department of Pharmacology from All India Institute of Medical Sciences, AIIMS Rishikesh. To her credit, she has done a good research work and has 58 publications. She has also published 3 chapters, and she has won many awards like Teachers Day Award in 2018 in AIIMS Rishikesh. She's also Associate Dean of Examination Cell at AIIMS Rishikesh, and talk on pharmacovigilance.
Thank you, Dr. Anand. Good afternoon, everyone. The topic that I have chosen today is global and Indian scenario of pharmacovigilance. I'll be covering my topic under these following headings. First, I'll briefly describe about the major historical events in the history of pharmacovigilance, which basically led to different regulations, which ultimately led us to use safe. A main thing after a new drug discovery that help us to bring out the safe drug use. And then I'll discuss briefly about the recent trends in international pharmacovigilance. Then I'll compare the Indian pharmacovigilance with global pharmacovigilance. And I'll discuss briefly about the challenges and recent trends of pharmacovigilance in India, and finally future directions. Now, coming to the major historical events in pharmacovigilance. So when we go to the history part, we will see that there are various disasters in the drugs
safety, which ultimately led us to formulate various regulations, after which we try to improve the mistakes that we have done. So first was the 1937 May sulfonamide disaster. After this disaster in 1938, preclinical toxicity and pre-marketing clinical studies were made mandatory. Then in 1950s, when it was found that chloramphenicol is associated with aplastic anemia, after that in 1960, hospital-based drug monitoring program was made mandatory. Then it was not until thalidomide disaster in 1961. After that, in 1968, the International Drug Monitoring Program was with cardiovascular risk. After that, it was realized that the drug companies have to have a mandatory risk management plan. And in 2005, European Union, they made it mandated that companies had to give the risk management plan of the drugs also. Now, pharmacovigilance, when we define it, it is a science and activity related to the detection, assessment, and understanding of any drug-related problem. And to bring about all these detection and assessment, we rely on various sources. So the various sources of pharmacovigilance are basically, we have different data from preclinical trials, we have post-approval safety studies, then there are certain spontaneous reports which are given by voluntary patient itself or healthcare professionals. And we also have safety data from various databases like FDA, AIIMS, VigiBase, and Ultravigilance. Now, since we have data from these various sources, so it is important that there should be consistency in the collection of the data, so that the bias is minimized and we can facilitate the analysis in the global perspective. So all the data, it is interpreted in a similar way all across the globe. And probably because of this, the importance was realized. That is why vigilance, they basically should have the same standard. And who are working in, they should have certain certified criteria, so that there should be minimization of the bias in the different pharmacovigilance setup. Now I'll talk about the organizations which are involved in the global oversight of pharmacovigilance. So basically, most important is World Health Organization. The World Health Organization from 1978, it is maintaining Uppsala Monitoring Center, and it is the international database which is having VigiBase, it maintains it, and most of the adverse drug reporting data, it goes to VigiBase. Especially in India also, all the VigiFlow, whatever data we are uploading, it goes to VigiBase. So it is maintaining the international database. Now, the next organization is International Council of Harmonization, ICH. So it is a global organization which is founded by the contribution of European Union, US, and Japan. And basically, it recommends the global standards for drug companies and drug regulatory authorities. So majority of the guidelines that are followed by the post-marketing surveillance, they are basically by ICH. There's one more organization, Council of International Organization of Medical Sciences. This council basically provides guidance on drug safety related topics. These recommendations from CIOMS. And then after that, the last organization that I want to mention is International Society of Pharmacovigilance. It is basically an international non-profit organization, and it was established in 1992 as a society of pharmacovigilance in European state. And it fosters basically pharmacovigilance both scientifically and educationally. So the aim of this organization is to enhance all aspects of safe and proper use. So in their meetings and all, basically all the relevant topics regarding to pharmacovigilance and whatever current issues are there, they are usually discussed, and they are basically discussed in this meeting and all, and they try to improve the pharmacology practice all over the globe. So now I want to mention a little bit about regulatory pharmacovigilance or post-marketing surveillance, because most of our spontaneous drug monitoring, it is based on voluntary reporting. But after a new drug approval for a few years, the regulatory authorities, they made it mandatory that post-marketing surveillance for safety data has to be there. So basically in most of the developed countries, pharmacovigilance is developed by, it is dominated by regulatory aspects, and it was initiated by only after 1992 by ICH process. And major onus for pharmacovigilance after the drug approval is on the market authorization holders. And they are mandated to submit to regulatory authorities all the data which is related to the safety aspect of the new drug. And basically, they have to submit expedient ISRs, periodic safety update reports, periodic best effect risk evaluation reports, risk management plan, and also all the results of the post-authorization studies, safety studies. Now, in this, for the guidelines for these regulatory pharmacovigilance, it is basically given by Good Pharmacovigilance Practice Manual, which was given in 2012. And basically, in this GVP is nothing but a set of measures which are drawn up to facilitate the performance of pharmacovigilance in European Union. And basically, it applies to market authorization holders. So it's sort of a Bible for them. They have to follow this when they are conducting any study and presenting the data for post-marketing surveillance after the approval of new drug. And it covers all the medicine authorized in national level in European Union. And also now, because many times the drug regulatory organization are telling the companies to do a post-marketing surveillance study. They don't have to rely only on voluntary reporting, but they have to conduct a safety study for better safety profile of a drug. So now, CEPP is the organization which has given the guidelines and standard how a pharmacoepidemiological study can be done. And now it has been made mandatory that all post-marketing surveillance studies, they have to be registered. Just like we have a clinical trial registry, like that we also have now a post-marketing surveillance registry where all the newer safety data studies have to be registered. Now, coming to the recent trends in the international pharmacovigilance. So basically, there are certain, now the basic thing is that we don't only say about that the drug, only the voluntary reporting or safety aspect of the drug has to be covered. Now the thing has shifted to other aspects also. For example, now the major onus is also on medication error. So medication error is one of the most common cause of reversible cause of ADR. So if we can prevent a medication error, we can prevent a lot of ADRs. So now the focus is also on medication error. Then we have vaccine surveillance. The COVID has taught us many things, that we have a clear safety data regarding the vaccine. Promoted nowadays, they are like, it has pharmacovigilance program has thrust on the pharmacogenomics, even though there is a lot of talk about pharmacogenomics and drug dynamics, pharmacodynamics, but as such, there are no clear-cut guidelines how to use it for the safety use in pharmacovigilance. So nowadays, studies are also there how to minimize the risk of adverse drug reaction due to by the pharmacogenomic studies. And then about the medical safety devices, now thrust is on also not only on drugs, but medical safety devices. And we have seen vigilance program. It is running in our country. Now we are also not only capturing the adverse event of drugs, but also about the medical device and device safety. Then eco-pharmacovigilance is coming in a big way. Also, the thrust is nowadays to capture the special group population, like drug safety in older population or pregnant female or female woman health and all those things. So specific areas are being targeted. So we can capture the risk factors which are associated and identify the risk factors associated with this special group. And finally, real world evidence. Now, since now the era is coming of artificial evidence. So real world evidence is coming in a big way, and pharmacovigilance has to adapt to utilize this data of real world evidence. Now, all these topics that I have few of these sessions topics. Now, I would really like to talk about one slide about real world data. Real world data, what is real world data actually? It is a routinely collected data from variety of sources apart from clinical trials. Uske alawa jo bhi data hota hai, it is the real world data, and it includes all the patient health status and delivery of healthcare. So basically, real world data will include all the electronic health records, claims and prescription data, and registries. And nowadays, the data from wearable devices, M-Health app, and social status also is being considered as a real world data. So, and this data, as of now, it is underutilized source of information for assessing the public health impact. And the basic problem with utilizing this real world data is that there has a lot of operational, technical, and methodological challenges, because it is a free data available, and how to interpret in terms of pharmacovigilance, it is a real issue nowadays. So usually it is being handled by using of AI text mining technology. So we have one full session dedicated to artificial intelligence and pharmacovigilance and drug safe use. So in the further session, I think the other speakers can give a light on that. Yes, CTSO, and US and FDA, it is US is FDA and European Union is EMA. The authority responsible for pharmacovigilance is IPC, NCC, and IPC in India. And European Union and USA, we have different authorities responsible for that. Now, the guidelines that are being followed for pharmacovigilance, in USA, it is good pharmacovigilance practice and pharmacoepidemiological assessment. In European Union, it is good pharmacovigilance practices. And in India, we had PSUR and Schedule Y. But recently in 2018, the pharmacovigilance guidance document has been released for market authorization holders, and they have to follow that data, that guidelines. The online reporting system in India, we are still using WHO system. We are sending all the data to VG-base, but USA and European Union, they have their own, they have maintained their own online reporting form. And the pharmacovigilance database is also different for them. They have their individual pharmacovigilance database, but we are using through VGFlow, we are uploading all our data in the WHO database. So as such, India doesn't have its own database. We are all giving all the data to WHO. We have not maintained our It is an initiative taken by FDA, where all the data which I have told about real world data, they are trying to analyze that data in that Sentinel initiative. So they basically, all the voice, consumer voice record problems and all those things, they are captured in Sentinel data if it is drug related problem and all. So they are trying to analyze, they are trying to use the AI to use it for the drug pharmacovigilance. Now coming to the ADR form, here again the major difference is that in India we have only one ADR form, but in USA we have two types of form. One is voluntary ADR form and another is mandatory reporting form. Similarly in European Union, they have three different types of forms. Then coming to period 6 safety reports, in India, their also timeline is little different. India, we follow first 2 years is 6 months and next 2 years it's once a year. We follow nearly as like European Union. But in USA, it is little different. 15-day alert reports has to be given. And after that, first 3 year quarterly report has to be given annually. Now, the risk management system that we use in India, it is now I have already told that 2018 one guidelines has been released for the all the management system. Now coming to the challenges of so this was the comparison between India and other global developed country में pharmacovigilance. Now coming to the challenges that are faced in India. The basic challenge in India is that here again, the underreporting, gross underreporting of ADRs is the major problem, because most of the things we rely on the spontaneous report. And until and unless those who are working in pharmacovigilance center, we know that spontaneous reporting is still very less. Whatever ADR we are getting, most of the time they are out of the project that we give to our students, or we are doing any thesis of the pharmacovigilance, then we get the lot number of ADR. When we basically solicit the ADRs, but spontaneously healthcare professional or any customer, it's very less. The number is very less. Then the second important challenge in India is that we don't have any regulatory inspections in pharmacovigilance. Like for example, in hospitals, we have now NABH accreditation and all, so they know the standardize, how to do standardize this thing. For ethics committee also, we have a standardization. But for pharmacovigilance sector as such, we don't have any regulatory inspections. So the center is there, it's working, but everybody works on their own, like not clear inspection is not there as such for pharmacovigilance centers. Then there is also a or they have maintained their own database. We give all our data to WHO, and it is interpreted at global level. And another important problem in India is that most of the places, in developed countries, the drugs are given by prescription. So usually the doctor knows which drug, we know the prescription that which drug patient is taking which drug. But India, self-medication is a major problem. Most of the times patients self-medicate. A new drug is released in the market, a patient is taking a new drug, but he will self-medicate with other drugs. So the drug interactions, due to that, it is sometimes very difficult to monitor. So so we have to here clearly promote the spontaneous reporting by the patients itself, so that we can capture this self-medication while drug interactions with the new drug and all. Now, to overcome all these challenges that I have highlighted in the previous slide, now pharmacovigilance program in India, they have done many things. We are really trying hard to overcome all these challenges. First, we have in pharmacovigilance system, we have a toll-free number, and we have Android mobile app, so that patients themselves can upload, anybody can upload in an easy way the ADR reports. Then feedback forms, separate feedback forms are available for health. India is a vast country, different places have different languages. For that, now we have nearly 10 forms in 10 languages, which can be used in different places of the country. And then National Pharmacovigilance Program is now collaborating with national health programs. So the data from the National Tuberculosis Control Program or NACO AIDS Control Program or immunization, all can be taken together and entered in the database. And then there are regular educational and training activity in pharmacovigilance. So pharmacovigilance program of India, basically it has made many regional centers. AIIMS Rishikesh is also a regional center. So we keep on having the training sessions, and so that people and healthcare professionals are made familiar with the pharmacovigilance program of India. And also many places courses are being started in pharmacovigilance, especially in B Pharma and all. And then the last thing that has been done is that now in 2018, mandatory safety reporting has been mandated by market authorization holders in 2018. So these are the recent things that had been done in India. Now coming to the future direction. So the future direction of pharmacovigilance advanced therapy medicinal products like CAR therapy or gene therapy and all. The way pharmacovigilance, but till now pharmacovigilance was very easy. We were taking a chemical entity and we were knowing some of the ADR, we have to just monitor it. But how the gene therapy is given and how this CAR therapy is given, there are different things, different set of problems which can occur with these type of therapy. So we have to, pharmacovigilance program has to adjust, to predict it, we have to adjust according to that. Then digital therapeutics is going to come in a big way. Now we are all talking about AI. There's talk about that the patient can tell his symptoms and the app can tell what drug he has to be needed or what his symptoms are, what his diagnosis or not. So all those things that like we are doing safety data with the medicinal devices, we have also to develop something for digital therapeutics to assess whether it is working fine or not. And then the next thing that is there, it is about how to use the real world data, how to integrate with that AI system and how to assess it for the benefit of pharmacovigilance. And lastly, it is the consumer involvement that we have to really see. Patient safety first and patient is a priority. Like we have seen in COVID time, there was clearly. So the population, so the consumer knows clearly what is the status with the vaccine, because we had seen a lot of data was being circulated in WhatsApp and all the things. So many people, they were not taking vaccines and all. So we have to have a direct communication with the patients, a clear-cut communication about the safety aspect, so that they can take an informed decision. And so this was about the future direction. Now coming last, I just want to highlight the status of AIIMS Rishikesh. We are an AIIMS center. We started on 2014. And till that time, we have really, we had approximately reported approximately 5,000 ADR reports. We have been doing regular pharmacovigilance activity. It was not there within the COVID time, but we try to do one activity every year. And also we incorporate a lot of short-term student projects, like the people who are doing M-Pharma, they come to do the projects here. So we have nearly 20 projects have been done in our AIIMS center. And we have also tried to publish some of our work, nearly 10 publications we have done from the Pharmacovigilance Center of our country, for our AIIMS center. Now, finally, to conclude, each historical event in the history of pharmacovigilance has led to certain regulations which has made and consistency in the collection of the data safety is important so that it can be analyzed globally at the same way. And for that, guidelines are continuously being updated for regulatory pharmacovigilance, and they are being introduced, and with every mistake, a new thing is corrected in those things, whatever lacunas are there. And pharmacovigilance as such, it needs to be updated to include the upcoming future trends, that is advanced therapeutic medical products, digital therapeutics, and real world data. Thank you everyone for your patient listening. And I think with this, I conclude my session. Anybody else?
Anybody wants to ask any questions? They may ask. Mike. Can I have one mic in the audience, please?
Thank you, ma'am, for your wonderful session. But just I have a query, ma'am. What is eco-pharmacovigilance in international pharmacovigilance, ma'am? What is eco-pharmacovigilance?
Yes.
What is this, ma'am?
What is eco-pharmacovigilance?
Yes, ma'am.
See, I think eco-pharmacovigilance is basically the whatever drug we are using, how it is interfering with the environment. And so this is basically eco-pharmacovigilance, and how it is like interfering with the environment thing. Like most of the drugs that we are using, sometimes they are dumped in the they are dumped like that without being destroyed. So how it is affecting our environment. This is the eco-pharmacovigilance, and we have one full session for eco-pharmacovigilance. So in due course, I think you will know.
Yes, ma'am. Ma'am, I have second query that, ma'am.
Yes.
What is good pharma?
Pharmacovigilance practice is basically a document. It is released from European Union, and it is for the market authorizing holders how to follow the post surveillance studies. And in India in 2018 we have now CDSO has released a manual for that market authorizing holders, and now it is mandatory for them also to report the drug safety data.
Yes, ma'am. Thank you so much, ma'am. It was very helpful.
Thank you. For the want of time, we will conclude the question session now. The other questions can be taken during the tea break. And I thank Dr. Manisha Vist for us providing an overview of pharmacovigilance, the various databases available, how the Indian pharmacovigilance compares against the global counterparts, and also the various deficiencies in the area. And finally, you had mentioned about the role of AIIMS Rishikesh in pharmacovigilance, which is quite impressive. And AIIMS Rishikesh is definitely known for its pharmacovigilance program throughout the country. Thank you for that. With that, I will request Dr. Jayakaran to introduce our next speaker, Dr. Renu Gulwani. Thank you.
Thank you, sir.
Including 2 case series. and she secured first position in oral presentation in a conference in SRMS Bareilly. So with this impressive CV, I would like to invite Dr. Renu Kulwani for the lecture on WHO pharmacovigilance indicators. Thank you.
Thank you so much, everyone present over here. A very good afternoon to all of you. I, Dr. Renu Kulwani, am going to present here the WHO pharmacovigilance indicator. Indicator literally means something that leverage or gives a state of something. So that means the indicator. When it comes to pharmacovigilance indicators, as we all know, the pharmacovigilance activity in India it's high time to have the interim evaluation of pharmacovigilance system in the India, particularly the nascent system in the developing country like India. So for this, I have taken this pharmacovigilance indicator topic just for the high time to need the assessment. So I'll cover my topic under following heading that I will define what is these indicators are, what are these types of indicators, how they are categorized, and the status in the India. And finally, what challenges and limitation we are meeting in and what is needed for to overcome these challenges. Now, coming over to these pharmacovigilance indicators, they are particularly the measures for evaluation. It evaluates the baseline situation of the nascent pharmacovigilance system, the progress in the system, and finally, it assesses the services and the instrument provided by the pharmacovigilance facility or activity. So if we say basically it will assess at the pharmacovigilance facility or activity, it will assess the structure, the process, and the outcome, meaning by the structure or infrastructure. Program. So in nutshell, we can say that this pharmacovigilance indicator are going to give the information of measuring how well our nascent pharmacovigilance system is achieving its objective. So what objective we could get after using this tool as pharmacovigilance indicator? We could have the status of the nascent pharmacovigilance system. We can have the situation where it lies on. We can have the comparison of the pharmacovigilance facility or activity running at local area, at regional area, and at the national area. We can have at one center, we can have supervision over that activity. We can monitor the activity at the pharmacovigilance. We can have comparison from around the geographics of the India or the nationally or the globally. And we take appropriate action after identifying the strength and the weakness linked with the system. Now, as I said, after defining and telling this pharmacovigilance tool, I will go on to the types. What are these indicators are and what types of this? So basically, these indicators are of three types. Likewise, here also we have the pharmacovigilance score indicator along with the complementary indicator, and lastly we have the pharmacovigilance indicator for exclusively public health program which are running with the pharmacovigilance setup. So this score indicator, which are the prime and the foremost one, they are giving the basic information of the pharmacovigilance facility and the activity, and they are highly relevant. They are 27 in number. The complementary indicators are 36 in number. They give the additional information related to the pharmacovigilance facility or the activity. And they are also useful. Sometimes they give the activity running over at high pace, not for the nascent. For the nascent, we can just go for the prime one, the core indicator itself, and that is 27. So these indicator, as I said, will assess the three areas: the structure, the process, and the outcome or the impact. So on that basis, both these main indicator like core and the complementary, both these main indicator are again categorized into three arena, and we will get the qualitative data, whether the structure is present or not, whether the policies are there or not, whether the financial sources are not. So this will give the decomitis or the qualitative data. When we assess the process or the running processing, running functioning or outcome, we will have the quantitative or numerical value. So we will have the quantitative data. So this core pharmacovigilance, which I have said, they are 27 in number, as they are going to give the information over the three level, the structure, process, and the outcome. These 27 indicators are subdivided into 10 structure, 9 process, and 8 impact or the outcome indicators. Same with the complementary, they are 36 in total, and they give information related to 11 structural, 13 process, and 12 impact indicator. So basically, we have this much of data. When it comes to assessment of the pharmacovigilance activity, we will get 63 indicators, 27 core and 36 complementary. But as we are short with the time, the session is compact, we will mainly converging our topic only towards nine process, 8 impact or the outcome indicator. So starting with the core structural indicator, as I said, it will give the information related to the system running, the structure present, infrastructure availability, I mean to say. So what are the indicators? What are the seeking information in these indicators are, as they are 10 in number, they are CS1, 2, 3, and likewise up to CS10. So basically, they want the information related to the structure, whether the center at any area or regional, local area, it's having or not, where pharmacovigilance center is there or not, the statutory provision is not there, whether regulatory authorities are there, financial provision is there, human resources are available or not, ADR forms are available or not, ADR forms for medication errors are there or not, counterfeit drug, ineffectiveness of the drugs, misuse of the drug, and ADR for the general public are available or not. It will give the information related to yes or no, whether present or not present. It will give the qualitative data. Like ADR's collection process is there. Some person is there to collect the ADR, or whether the under this ninth structure, we will have whether the pharmacovigilance facility is disseminating this information in the form of newsletters or there is any advisory committee. So this is the 10 structural indicator. Going towards the 9 process indicator, as is this will give the running process of the system, whether the pharmacovigilance facility or system are running properly or in a standard parameters, like 9 parameters they have given. What are the total number of the ADR reported in previous year, total ADR in a database in a year, total acknowledged or feedback data of the ADR, whether the ADR reports are causality, whether their causality assessment been done or not, whether they are satisfactory completed or not, or their therapeutic ineffectiveness ADR are incorporated in this ADR system, medication error ADR, whether there is pharmaceutical companies registered with this center to report the ADR, or active surveillance system is running facility wherever the local, regional or the national giving result or the changes in the system or not. So the achievement or outcome 8 indicators are whether the nascent pharmacovigilance activity or facility have generated any signal in the previous 5 year, or there is regulatory action being taken like product label change, like withdrawal of the medicine, safety warning issued, or restriction to the use of any medications. Or it will give the outcome in the form of whether there is medicine related hospital admission or not, or in per 1,000 patient there is death or not related to the medicine, per lakh population whether there is death related to the medicine, or what is the cost of the treatment related to the medication problem, medicine related hospital stay and hospitalization. So this is how we will get 8 outcome indicator. So collectively we will have 27 core indicator, 10 structural, 9 process and 8 outcome indicator. So based on this, as we have the information of these core indicator, based on this, as this is the time pharmacovigilance, some studies has been conducted to assess this pharmacovigilance system in India also. One of this is a study done by the Karen Megater in 2015. I must say in 2015, in that year in which this indicator guideline or this indicator was released by the WHO at the same time. These studies were done by the Karen Megater in 2015. In that study, the India got aggregate score of 15 out of 63 indicators outcome. 63 means 27 core and 36 complementary. So India was lagging behind from many other countries, especially in the developing countries. So on that basis also, recently in 2022 also, the Hamza Qureshi did the systematic review over comparison of the pharmacovigilance indicator activity among many developing countries. So in this also, India lies at very behind and it need to be upgraded. Very important point to be noted here is that in this, the green part is showing the outcome indicator. So in this study, we can note that so that we can identify the element for sustainable pharmacovigilance strategy and areas of improvement. So India is facing so many challenges and limitations, no doubt. It has resource constraint like human resources, the financial resources. The system is very complex and the quality of the data of the area reporting is also not up to the mark. So studies are much needed to upgrade the quality of the area reporting. The system should be simplified. Putting the safety at every side. Thank you so much from my side.
Thank you, Dr. Anu, for such a wonderful and very good summary of the indicators. Now the session is open for a few questions.
I think you have very well elaborated the data which is prevalent or present in WHO. We have been making efforts since long, and physicians do not report. It is a rare thing when the physician reports. Now, what is happening is that we have established centers, pharmacovigilance centers in different pharmacological departments. And those centers, what they are doing is known to everyone. Another thing is the reporting is done, should be done by physicians, by dentists, as you said, by nurses and paramedical staff and pharmacists. Actually, none of these is trained in pharmacovigilance except that new regulations have come for MBBS course. Activity in dentist courses, clinical pharmacists are not available. So we just talking in the sky, what is happening, what should happen, what we should do. The Indian Medical Association, we made efforts, and all India level, a meeting was held in Hyderabad. I was present in that meeting, and one or two representatives from Uppsala also came in that meeting. And thereafter, no effort was made by Indian Medical Association also to propagate pharmacovigilance. So what is happening is that we only talk. Only few people are working. And on that basis, if we create data and all that, so that is not justified.
Indian Pharmacopoeia Commission. I don't have a question, good presentation made by Madam. But I just want to supplement here that the pharmacovigilance indicators are an important tool for the WHO NRA assessment also. And WHO has come out with the Global Benchmarking Tools 2021, where pharmacovigilance is one of the important functions among 9 functions as per the WHO GBT 2021. There are total 9 functions, 62 indicators and 268 sub-indicators. And WHO NRA assessment in respect of vaccines was done last in 2017, where India passed at a maturity level 4, so got an advanced system of pharmacovigilance, as we qualified 100 marks in the vigilance indicators, and the next WHO NRA assessment in respect of vaccines is due and the preparations are ongoing. So this is what I just wanted to supplement to this topic. Thank you.
Thank you so much.
Thank you.
Sir, this was, as I told you, this was best of my knowledge that I can search on the internet as going through the IPC website as well as on the CDSCO on the WHO side. I could find, I myself was searching about since 2015, there was no indicator assessment over the India, no study was conducted. So that was doubt in myself also. I was also in doubt why there was no study and how this lagging behind. Since 2015, we are just giving this data. So that's why, and thank you so much for updating me. And thank you to all for patience listening.
Thank you, Dr. Renu. Thank you very much.
I request Dr. Jayakaran Charan to felicitate Dr. Renu Gulwani with a memento for an informative talk. Now I request Professor Shailendra Handu, Head of the Department Pharmacology, AIIMS Rishikesh, to kindly come up on this dais to present a token of gratitude to the chairpersons. Professor Puneet Dhamija sir, Department of Pharmacology, AIIMS Rishikesh, to kindly come up on the dais to present a token of gratitude to the chairpersons.
It is my pleasure to introduce the third session of this conference, Medication Errors and Drug Safety. We have gathered some of the most distinguished experts in the field who will share their insights and experience in preventing medication errors and ensuring drug safety. I extend a warm welcome to the esteemed chairpersons of the third session, Dr. Shoaibal Mukherjee, consultant at BIRAC, and Professor Vandana Roy, Head of the Department of Pharmacology at Maulana Azad Medical College, New Delhi.
Is in the auditorium. He's the chairperson for this meeting. Please call Dr. Jayaprakash. He's in the auditorium. Good. Okay.
I invite Dr. Jayaprakash to kindly chair this session. So kindly be invited.
आ गया ना? हाँ, अनम्यूट कर दिया उनको। अभी अनम्यूट कर। म्यूट करूं? आ गया। म्यूट कर दो, म्यूट कर दो। अभी नहीं बात।
I request chairpersons to kindly introduce the speaker.
I am very grateful to the organizers for inviting me here. And we have the first speaker, Dr. Ratinder Jhaj. Dr. Ratinder Jhaj is a professor at All India Institute of Medical Sciences at Bhopal. Madam has 55 publications in national and international journals of repute. She is also the coordinator of AIIMS at AIIMS Bhopal, and she is also the coordinator of the RTC for Madhya Pradesh and Chhattisgarh regions. She is also the member of State AEFI Causality Assessment Committee, Society of Pharmacovigilance India. She is a life member, and she also represents as a member of International Society of Pharmacovigilance. With this background, I invite Dr. Ratinder Jhaj to please present the topic on the
much time, and a disclaimer that we are going to be a little late for lunch, but I'm not responsible for that. So actually, my topic is reporting of medication errors, but I saw in the schedule that there was no session on medication errors. So I will be giving a very brief introduction to actually what are medication errors. And if time permits, how do we prevent? That's also not part of the, the title. So that's quite a task for 20 minutes. And to save some time, I have removed overview and summary slides. Okay, so with that, let me not waste any more time. So I'm starting right away with what is a medication error. So I think all of us last year in TVs, we have heard of this news. I'm purposely not, revealing the name here, but of a nursing professional being blamed for the death of a 75-year-old patient due to a wrong injection. We've also heard similar reports in the past, wrong, injection being given to a patient leading to death, or a drug being given in the spine, which was not supposed to be given to him. Closer home, actually, we've had such problems at AIIMS Bhopal. So this is actually a prescription from none else than our office attendant in AIIMS Bhopal Pharmacology. So he was actually prescribed eye drops cyclosporin for an eye inflammation, and he was dispensed cyclopentolate. So he put that, and then fortunately he told us, the next day ki madam bada blurred lag raha hai vision. Then we discovered that he was actually putting cyclopentolate in his eyes. So we stopped it. We've also had, in fact, two reports of one, fortunately, the patient survived, and one was a death due to methotrexate. Methotrexate, we all know, is often given weekly. So one patient, instead of taking it weekly, was taking it every day, and that also BD, and landed up in severe leukopenia. But fortunately, this patient survived. Another patient, this prescription is from outside, actually AIIMS Bhopal, was being given methotrexate 75 milligram every other day, but that itself is a very high dose, and the patient so many definitions. The most clear definition which I found was, so it's an unpreventable, it's a preventable event that may cause to inappropriate medication use or patient harm. So the words which I want to stress on are bold here. So it is medication error is something that is preventable, first of all, and it may or may not cause harm. It doesn't have to cause harm to be called a medication error. Okay, and this happens while the medication is in the control of the healthcare professional, patient, or a consumer, which means The error could be made by a healthcare professional, could be a pharmacist, could be a nurse or a doctor, or by the patient themselves. So this is a definition by NCCMRP. That's the, it's an organization of patient safety organizations in USA. A simpler definition by Dr. Jeffrey Aronson is that, which is also used in the EU document on medication errors, is that a medication error is an unintended failure in the treatment process. So here failure word is a little error. And again, in this definition, so it goes on that it leads to or has the potential to lead to harm. So again, medication error is an error, but which may or may not lead to patient harm. Now, so there are these related terms which we need to be aware of. So there is something called a patient safety, incident. So patient safety incident is anything unintended, unexpected that happens to a patient during healthcare. This may or may not be related to medication error. So like a wrong, say, kidney being removed for a patient, or, I'm just giving an extreme example. So that's a patient safety incident, but that's not a medication error because here no medication is involved. So medication error is a kind of, it comes under the ambit of patient safety incidents. Then, so this Venn diagram kind of, shows us, can I have a pointer or should I use this? Yeah, okay, I'll just use that. So like we all know, for lack of time, I won't take too much time over this, but we all know that all adverse events are not adverse drug reactions. So some of the events are reactions. Similarly, all medication cause adverse events, but they are not adverse drug reaction. Like a cannula, if it's not, inserted properly, and if it punctures the vein or causes hematoma, so that is a medication error that is causing harm, but that harm is not an adverse drug reaction because it's not a drug that's involved. And finally, so we have this overlapping, rectangle where medication errors are causing adverse drug reactions. So in a nutshell, medication errors can be causes of adverse drug reactions. So, but all medication errors do not cause adverse drug reactions, and obviously all adverse drug reactions are not due to medication errors. Now, there are another two kind of things that we need to know of, what is called an intercepted error or a close call or a near miss, as the name suggests. So there is some error in the process, but that has been intercepted before reaching the patient. And a recent example is, I think we've all seen in the news, Abbott, there was a labeling error in thyroxine by Abbott that the 25 microgram vials were labeled as 88 microgram. Had reached the patient, there would have been harm, but that was prevented. Then there is potential error, and that is what we will look at very briefly. There are situations where there could be an error, but an error has not happened. So this is again just a summary of that. I think I can just skip that. I've kind of already explained without a pointer. I find it a little challenging to explain that, so I'll just skip that. That was just a summary of what all I had till now said. So medication errors could happen at any process during the medication process, that is right at the time of writing a prescription or dispensing, or even before dispensing, storing a drug, administering a drug, preparing a drug before administering, and as we've seen, while the drug is being used by a patient, or even monitoring therapy. If that's not done properly, it could lead to an error. So that is one way of classification. Another broad classification, we can say these could be errors of omission or commission. And as I think everybody can understand, that means either something that should have been done has not been done, or something that should not have been done has been done. Lack of time, and for simplicity, I'm skipping that. So that's, knowledge-based error, skill-based error, etc., which means, or a memory-based error. So which means an error because of lack of knowledge, or an error because of a problem with skill, or was the error because of lack of memory. So that's another classification, but I think the 2 classifications per session are enough. So now I'm not going to go into details of all kinds of errors. Prescription errors, we could be here for a day talking about prescription error. But just to say that prescription errors again are of 2 kinds. One, you could make an error in choosing the drug. You're giving, you're prescribing a drug to a patient for whom the drug is, say, contraindicated, or you're writing you are choosing to write a wrong, a high dose, etc. Like the methotrexate in our example, 75 milligram every other day for a post LSCS vaginal bleeding is actually not a good indication for methotrexate. Or so that those are also called prescribing faults, or there could be a problem in writing a prescription. I think I should just close that. And this is just an the frequency, etc. So that's called a prescription error. So that's where I'm going to stop about errors. Then, as we saw, the problems could be the drug or device related, meaning there could be problems either if there are, issues with the name, there are confusing or similar names. Like I'll be coming to that. LASA, everybody's heard of that. There could be misleading or similar appearances between different kinds of drugs. The packaging could be a problem, or the labeling could be a problem. So now I think all of us have heard of LASA. I think LASA is better than the other short form in India. So what we mean by LASA, look alike and sound alike drugs. So there could be drugs names that sound alike, and which could be the generic names or the brand names like sertraline, cetirizine are generic names which sound very much alike, though they look different. Diamox, Zymox are brand names that look alike while the drugs are so different. And these are especially problems when telephonically or verbally instructions are being given about a drug. Similarly, a prescription, or Zentax, Xanax, which again could be a problem when you are writing a prescription. So, this in turn could lead to an error in either dispensing or administering a drug. And then there are these drugs, cycloserine, cyclosporin, which both look and sound alike. And in our case, cyclosporin got confused with cyclopentylate. So these are the drugs that can cause medication errors. Now, for these drugs where the names have already been given, there's hardly anything can be done. But the regulatory authorities, while approving a new drug name, they keep this in mind that, a new drug name should not resemble an existing drug, so that to avoid these problems in the future. So this is just another example. Lamotrigine, lamivudine, and now, when 2 drugs have similar names, one saving grace is often that the doses are different, and that at least, can alert somebody that, this drug must be wrong. But then, lamivudine, lamotrigine, both of them are available in different strengths, but 100 milligram is a common strength for both of them. So they have similar looking. I'm sure all of us have seen this circulating over WhatsApp a couple of years ago, and I even contacted Dr. Jayaprakash about it to find out whether what IPC had done about it. And in fact, now and then we try to find out whether they are still available, but IPC had directed the companies to change. So at one time we did have common brand name for totally different drugs which were available. So that included pantoprazole, metronidazole, totally different drugs, but very similar brand names, but this situation has been now corrected by CDSCO, and the manufacturers have been asked to change drugs. But this was a disaster waiting to happen. So that was about similar names. Then the drug appearances could be similar. Now, there are a limited number of shapes and colors that tablets or capsules can have, or the packaging can have. So we are not saying that, Brufen should look different from paracetamol or amoxicillin. Anyway, that's not safe to say ki haan, Brufen lal hota hai or penicillin or tablet. If those within a drug, different strengths, it is good to have different colors so that there is less confusion. And similarly, syrups, paracetamol syrup comes in 2 strengths. So it is that actually is happening, that the different strength packaging should be, different, so that there are less chances of mixing up. So I've kind of covered this. And similarly, a regular tablet should have a different look than a sustained release tablet, or a regular injection of the same drug should look different from a depot injection. So that also reduces the errors. And this is just an example. And these are not even, Indian packaging, like we often say, ki India mein acha nahi ho raha hai. So this is like citalopram tablet, packaging of 2 tablets, strength. Everything is exactly same, only there is just a different in strength. And similarly, Montelukast. So it would be helpful if these packaging colors for different strengths were different, would, save errors. Okay, so with that brief introduction, I am now going on to reporting of medication errors. So because till we know what they are and what we remember in reporting, even potential or intercepted errors can be reported. They will usually be reported to a patient safety organization or a reporting system, maybe not to the typical pharmacovigilance system, but they should be reported, as we'll see. So where you report will depend upon the type of error and what it has led to. And in that case, so we can divide it into these 4 types. So we could have an error where, so an error has happened and a harm has happened. So say like methotrexate, taking the first example, the patient has, taking by mistake instead of once a week, has taken it twice a day, and the patient has had leukopenia. So this kind of an error usually is reported directly as usual because there is an adverse drug involved to the usual pharmacovigilance system. And maybe usually in the same actually ADR form, and some countries or even some institutes may have a different medication error reporting form. Now, the other kinds of errors, so there could be an error where an error has happened, but there is no harm. There could be an intercepted incident reporting systems, which could be local. Local means it could be within the hospital, it could be in a set of hospitals, say in the same region, or it could be national patient safety organizations. We'll just have a brief look at each of them. And there should obviously be a communication between the traditional pharmacovigilance system as well as the patient safety organization, so that we can share the communication. Now, this is looking like a little busy table, but we've already seen at the first 3 columns. So just to give you an idea, so when we are reporting, if we are reporting to a patient safety organization or a system, it's the coding is, the terminology is a little different. And if we are reporting to a pharmacovigilance system, the terminology is a little different. So if there is an ADR, as we've seen, we report to the pharmacovigilance system and we fill a traditional ICSR, that is the individual case safety report. If there is no ADR, or if there is an intercepted error a patient safety organization. But in case of an MH, in case of a manufacturer, they have to include these in their PSURs. So when they are giving their periodic safety update reports, there they should summarize any of the other errors, an error without harm, an intercepted error, as well as an error, even a potential error. So the idea is so that you can work out ways in which, because today's potential error or today's intercepted error or today's error without harm can be an error with harm tomorrow. So we do want to collect that data, and usually the regulatory authorities also do want that data from an MAH, maybe not in an ICSR form, but at least in a separate form. And actually WHO is also now working towards kind of uniform system of reporting all these medication errors. And so in a patient safety recording, as we see, so we call it an incident with harm, we call it an incident which is without harm, or just an incident, a prevented incident, or of course, when there is no incident, it is not applicable. In case of a pharmacovigilance system, we can say it's a medication guidance, which, and as I'll show in the later slides, for all of us who are using Vigiflow, there is an option in Vigiflow even to choose the option of a potential error, which is a circumstance or information that could lead to an error in the future. So looking at the system in USA, so like EU, USA also has obviously a traditional pharmacovigilance program run by the FDA. And here just showing you the HCP ADR form, where within the ADR form there is an option you can select that this ADR was due to a medication error, or you could report to one of the various. So there are at least 27 patient safety organizations in USA where you could report the patient safety error or a medication error. And as you can see here, both a consumer and a healthcare professional can report that. So these actually, all these organizations come under the ambit of the National Coordinating Center for Medication Error Reporting. And one of the, in fact, two single PSO. So this just to tell you what's, so just very briefly, so Australia also has its own system. Yes. So that was very briefly about two of the other regions. Coming to India, so PVPI, as we know, the form does not have any separate column or area where we can indicate that it's a medication error. And we, as far as I know, we do not have a national patient safety organization. There might be patient safety organizations or systems within hospitals. But as I said, now even when you're reporting an ADR, if you want to indicate that it is due to medication error, within Vigiflow, you can find that there is this option of, I don't know whether this would be visible, there is this option of selecting that if it was a medication error. There is an option of, that's the same thing, selecting that it was a wrong drug dispense, or as I said, even there is an option of selecting that there was a circumstance that could have led to error. So for lack of time, anyway, this all of us are using Vigiflow. So this is just to make reporting form. Okay, so as I said, only if time permits, I'll talk about prevention. Time is not permitting, so I will not talk about prevention. And this is, as I said, WHO is kind of making efforts to unify the information that is there in a patient safety incident or a medication error report. And this, all of us can, Google and see that. And for, medication errors, even more than ADRs, there are these potential liability and confidentiality issues. So that is something that has to be taken care of. Risk minimization, actually, I've already talked about just this slide that, one of the ways, so For the existing drugs with similar names, there's nothing really we can do, but in packaging, and even if it's not happened in packaging, while we are storing it in pharmacy, we could indicate, those names by using what is called a tall man lettering. And of course, we can use technology to help us, choose a drug correctly. We could use bar codes that's already being used in hospitals. We could, have, in fact, Government of India has, made it mandatory. I don't know when that's actually. All of you in pharmacology would have heard of this, especially PG students. एक PG question भी होता है, the Swiss cheese model of medication errors or pharmacovigilance is that if an error has happened at one place before it reaches the patient, if there are multiple opportunities for preventing it, and that's what we call a Swiss cheese model. And these are my references. And yes, I stop there. Yeah, so if any questions, I can try to answer that. Yeah, there's a question there.
Just take one question. Not sure the question.
Thank you, madam, for valuable information. Handwritten prescription and may lead prescription error. How can implement e-prescription? It may be reduce dispense record or drug safety record. How can implement e-prescription?
Yes.
Why not implement? Or how can implement e-prescription? It reduce
at AIIMS Bhopal, but as you know, e-prescription needs a computer and a network.
Okay.
So I think it's going to take time in India at all levels before e-prescriptions are something of the norm. They're definitely being adopted by a lot of hospitals. Slowly, we are having both. We are CDAC and NIC has hospital information systems, which are also moving towards e-prescriptions. But there also, there are chances of medication errors there, because we have what we, try to start filling a drug name. And that's what happened in the first case, the nurse giving, I think, vecuronium, Yash. So you start entering a drug name, you enter VE, and the system could complete that, like auto correction we have and that's how sometimes we send wrong messages, So we can never rely totally on technology, but technology can definitely help us.
Great, thanks.
Okay.
Thanks for that wonderful answer and a wonderful presentation, really. We learned a lot out of that.
Thank you, ma'am, for a wonderful talk. Judicious re-prescribing through clinical pharmacology reviews ensures better patient safety outcomes. May I now request our esteemed chairpersons to kindly introduce the next speaker, Dr. Shambhu Samajdar. Sir will be presenting online. So kindly introduce.
Thank you. So it's my pleasure to introduce to you Dr. Shambhu Samajdar. I have had some personal interactions with him in the past, so it's been a pleasure. Shambhu is an MBBS, MD, and DM in clinical pharmacology, but he has a number of other degrees and diplomas to his name. So he's got a postgraduate diploma in endocrinology and diabetes, and he does a lot of clinical work related to diabetes, I understand. He's also has a diploma in allergy, asthma, and immunology. He is a fellow of respiratory critical care. A multifaceted personality. Specialty clinic in Kolkata. He has 54 different publications to his name, national as well as international. And he's a recipient of the Indian Academy of Diabetes Award and Dr. J.C. Patel and B.C. Mehta Best Paper Award in 2021. So it is my pleasure now to invite Dr. Samajdar to make his presentation. Shambhu, you're on.
Thank you, sir. Thank you very much. It is a real honor to present in front of you. You are a role model for all of us. And also,
can you speak something so that we know that we can hear you?
Yeah, am I audible?
Yes, you are. Yeah, go ahead.
Thank you, sir. Thank you once again. And also,
Shambhu, one moment. If you can move slightly away from the mic, your voice is very loud and we can hear you very loud and clear. A little less loudly would be better.
Okay. I think the microphone setting can be changed from that side.
Okay, I will ask the audio people to do that.
Yeah, because I don't know how to actually moderate from this side. I think they can. So just at the onset, I want to thank Professor Shoilendra Handu sir, Professor Syed G.R. Rahman sir, and also Professor Puneet Dhameja sir, and whole team of Sopicon for providing me this opportunity to discuss about a very important topic on clinical pharmacological reconciliation, review, and feedback in ensuring patient safety. We all know this gentleman, the CRPF, who are there to save us from both internal and external atrocities. Today, we are going to discuss on another important arena, which can protect us from medicine-related atrocities, and that is CPRRF, Clinical Pharmacological Reconciliation, Review, and Feedback. So we'll discuss about why this is required, what is it, and how CPRRF could be utilized. We know this type of propaganda news always spread through newspapers against us, the healthcare professionals. And even yesterday, we lost our bright sister due to this violence. We should condemn that. But at the same time, we also need to acknowledge that these medical errors are the third leading cause of death, according to the US data, after heart disease and cancer. And we can see this sweet girl who had died due to medical error. Approximately almost 5.2 million medical errors occur annually, but this documentation is only the tip of iceberg. In India also, we can see some reporting from our Bengal newspapers, Times of India, Bengal edition, that half of Kolkata's elderly on multiple pills, victims of drug duplication. Again, little bit exaggerated report, but this was done due to one of our study finding, which was published. So you can see here also how they mention how we doctors need to stress on synchronizing medications. So similarly, we need to acknowledge these issues of multiple drugs intake, that is polypharmacy. And this is one paper we published very recently, how the polypharmacy and cardiovascular autonomic dysfunction is closely linked. In this study, we found the polypharmacy was significantly associated with CAN. And when we are talking about this, we need to address the WHO recommendation. WHO reported the scopes of clinical pharmacologists, and one of the major functions they had recommended long back, 1970, that is to improve patient care by promoting safer and more effective use of drug. With that background, this concept of clinical pharmacological review, reconciliation, and feedback of drug therapy came, and we can provide this service to different OPDs of clinical pharmacology. And specifically, we need to focus on different issues like drug-induced diseases, drug-related problems, including drug allergy. There are other services which can be again provided through this type of OPDs. But actually, what is this clinical pharmacological reconciliation review and feedback? In nutshell, we can see there are lots of scopes of this particular feedback, starting from we need to assess the prescription, whether the patient is consuming some drug which has no indication or indication for a drug, but it is not prescribed, necessary but wrong choice of a drug or regimen, or unnecessary redundant drugs. There is a scope of deprescribing there. Too much or too little a dose, adverse drug reaction is happening, or including some drug allergy, drug interaction, incompatibility for a particular patient, or overlapping of adverse drug reactions, adherence issues, and at the same time, the affordability and availability of the drug, monitoring drug therapy, specifically when in a background of chronic disease care. In case of some newly available drug, we need to have a prompt review of those drugs when it is used in some patient groups. Consider specific patient factors. This is an era of individualization of therapy or precision medicine. We need to take care of that with the help of obvious pharmacokinetic, pharmacodynamic rationale. Need to address polypharmacy. Yes, there is a need of legitimate polypharmacy, but we need to tackle some irrational polypharmacy. When we are talking about WHO criteria, they are recommending for an ambulatory patient for a given diagnosis, it is not more than 3 medicines usually needed. Yes, exceptions are there, like in case of tuberculosis, like in case of HIV. We need to address the adverse impact on quality of life. And obviously, the transition of care is a very critical issue where medication errors can happen. Again, the broad theme, broad goal of clinical pharmacological reconciliation review and feedback is medication without harm. We need to diagnose the drug-induced disease early, so prevention can be done for other consequences. And it is sadly but true, in general clinical practice, this drug-induced disease is something as a neglected differentials. We need to treat ADR and prevent their recurrences, avoid prescribing cascade. The mantra should be, specifically when we are tackling with our elderly population, start low, go slow, but go. Obviously, in case of acute care, critical care, we should not follow this mantra all time. In case of, just for an example, if I am treating one elderly patient with a compromised EGFR, but he is suffering from sepsis, we need to go by the formula of loading dose when prescribing antibiotic, not just going to EGFR criteria and reduce dose of antibiotic. So this type of modifications, this type of pharmacokinetic, pharmacodynamic applications is very critical when we are assessing our patients and treating our patient. So special prescribing considerations are important in specific populations, including renal, hepatic, compromised state, pediatric, elderly, and pregnancy. Let's discuss a real life case, a 68-year-old lady who is suffering from pain in both knee joints, severe weakness for last 5 days, suffering from pedal swelling last 5 months. So she was suffering from osteoarthritis, hypertension, diabetes, ischemic heart disease, and BMI. We can see she is quite obese. And lots of medications you can find here. The thing is that 6 months back, she was prescribed with a fixed dose combination which contained diclofenac for her low back pain. But to reduce now for this knee joint pain, she is consuming this diclofenac combined fixed dose combinations in a regular basis, twice daily. And for last 7 days, she was taking furosemide, which was given by some physician to reduce the pedal swelling. If we go by the lab reports, we can find there is the glycemic control is inadequate with hyponatremia and hypokalemia. The eGFR is quite compromised. And now if we just go by the medication list, we'll find the patient was suffering from pedal swelling for last 5 months. And there are some drugs like pioglitazone, pregabalin, amlodipine, which can cause pedal swelling. So without addressing that, what we did, we add a furosemide to reduce the pedal swelling. So ultimately that furosemide caused hyponatremia and hypokalemia, leading to weakness, and that may land up with other atrocities too. And the patient was also consuming for a long time that diclofenac containing fixed dose combinations, which was not at all good for that particular patient. So in this case, it is very obvious to do reconciliation. Again, if we go by the weight of the patient, body weight of the patient, we know that glimepiride, pioglitazone, even pregabalin can cause weight gain. But without addressing that issues, we are not providing actual treatment to the patient. So the pain due to the osteoarthritis aggravate due to the body weight. If we can tackle that body weight, if we can address that body weight, that could be better for our patient. So what reconciliation done? So all those agents which increase body weight, we deprescribe those. We know that GLP-1 reduce the body weight and it has lots of other good function. So we started that with injection dulaglutide. The metformin dose was halved due to the eGFR value. And also initially it was basal insulin for a few weeks, but after that dapagliflozin was given. We know the benefit, renal benefit of dapagliflozin. And also it is important, the patient was taking calcium carbonate initially and consuming PPI for a long time. So we all know how the PPI is compromising the absorption of carbonates containing calciums. So we need to convert that from carbonate to citrate. So this all done as a reconciliation advice, and we see the results, how the BMI reduced, how the pain decreased, and there were no pedal swelling. And the eGFR was improved. So this is why we need to tackle the situations. If I am consuming drug A and that drug A causing some adverse effect, we need to withdraw the drug A or minimize the dose of drug A. Instead of that, if we add some drug B to tackle the symptoms causing by drug A, and again the drug B is causing some another symptoms, I am adding drug C to control that. So there will be a cascade is ongoing, and the drug D will ultimately cause the same symptoms for which I am initially taking drug A. So we need to address the prescribing cascade, and it could be addressed by the reconciliation, CPRRF. And this was the case which was published in JAPI by our team. And now I want to focus on few numbers from each side of Atlantic. We can find the polypharmacy is there between 40 to 50%. And in Indian older population also, the data is suggesting almost 50% of our Indian elderly population has polypharmacy, taking 5 or more drugs. More than 10 or more drugs, 31%. But what is important, the potential inappropriate medication use in India is almost 28%. And when we are defining polypharmacy, there we can define it as quantitatively, the number is 5 or more. But qualitative definition is very important, where numerical count is not important. Important is appropriateness of therapy. Whether the potential benefits outweigh the potential harms, that is important. And when we are counting the numbers, we need to include the over-the-counter drugs, prescription of prescription drugs like traditional or complementary medicines too. So that is why the potentially inappropriate medications we need to identify. What is that? The medications with ineffectiveness or high risk-benefit ratio for a particular individual or group of individuals. So that we need to understand, and we need to deprescribe. And when we are talking about inappropriate medications, it is important to acknowledge if I am having my patient is taking more than five or more than 5 drugs, there is high chance that we miss the necessary drugs too. So underprescribing is often related with polypharmacy. And that also we found in one lady who was suffering from a unfortunate tibial fracture by a mild trauma. What happened? She was suffering from rheumatoid arthritis for a long time. She was consuming corticosteroids. But we all know when a patient is taking corticosteroids for a long time, it is important to add anti-osteoporotic therapeutics. But she was not given that. So this is what we want to mention, that even polypharmacy is associated with underprescribing. So deprescribing is not about just denying the effective treatment to eligible patients. This is a systematic process of identifying and discontinuing drugs in instances in which existing or potential harms outweigh existing or potential benefits within the context of an individual patient's care goal, current level of functioning, life expectancy, values, and preferences. This is a positive patient-centered intervention. It may have some inherent uncertainties and requires, that is why it requires shared decision-making, informed patient consent, and also close monitoring. So we need to diagnose the problem first, whether there is some use of an inappropriate drug. Then we need to make a therapeutic decision like withdrawing it, but we need to have a close follow-up, but need to check whether after deprescribing it, altering the natural history. I am deprescribed prazosin, but whether my deprescribing prazosin helped the patient to prevent further falls, this is also important to note. And that is why when we are talking about prescribing is not a snapshot. It is a continual process. It starts with therapy initiation, but continues with dose titration, changing or adding drugs, switching or ceasing drug therapies. And when we are talking about polypharmacy and deprescribing, we need to take care of our elderly populations. And for that, we need to evaluate risk by using some criteria already mentioned here, starting from beers to stop to start, like that. And we need to identify specific areas with treatment gaps in elderly populations, because here we also can see 1 in 5 prescriptions to elderly persons in primary care is inappropriate despite the attention that has been directed to the quality of prescription. So that is why we need to take care of these elderly populations. And when we are talking about elderly care, medication-related problems as inseparable from their broader life. Social and emotional context of medications and related communications are extremely important. And that is why we need to have special attention on that. We found in a large group of patients that anticholinergic burden is quite high in this group, the geriatric populations who were attending our clinic. We know that the anticholinergic burden, if it is 3 or more, that cause some atrocities, that cause some anticholinergic side effects, dementia, and other problems. One case here I just want to share. One 28-year boy, 28-year man was suffering from erectile dysfunction, taking lots of medications for last 1 year. Now, when he had visited us, we found she was taking for clemastine and an antihistamine for prolonged period. Along with that, she was suffering from headache, migraine, and taking amitriptyline. The anticholinergic burden of amitriptyline is 3. Anticholinergic burden of clemastine is 3. So 3 plus 3 is 6. So high anticholinergic burden, which cause parasympathetic dysfunction. And that is responsible for this man's erectile dysfunction. We just deprescribe it, we wait for 3 months and it was improved. And sometimes when we talk about drug-induced disorder, sometimes physicians may stamp a case as drug-induced disorder, but it is not actual drug-induced disorder. This was a case when the physicians were suspecting this SLE was due to allergen immunotherapy and referred to us. We found that there was no relation between allergen immunotherapy and SLE in this case. Similarly, again, a ranibizumab induced CVA happened, but it was unidentified. And second dose of ranibizumab was pending, but we identify them and prevent ranibizumab injections for the second time in that lady. So it is again for CPRRF, diagnosis of drug-induced disorder, drug-related problem, including drug allergy, is extremely important. And to diagnose that, we need to be very focused on history taking, especially the detailed medication history, the temporal relationship we need to identify. Then, yes, there are some importance of clinical examinations, lab investigations, special diagnosis for drug allergy cases like skin prick test, lymphocyte transformation test, or even we can thought about the HLA phenotyping, which can prevent drug-induced disorder. We can predict drug allergy by HLA phenotyping. We know about HLA phenotyping with carbamazepine. We know the link between allopurinol-induced SGS and specific HLA phenotyping. Sorry, this is in Bengali, but it is mentioned that we in School of Tropical Medicine under the leadership of Professor Shantanu Kumar Tripathi, we had started the OPD, and the headline is, this OPD was for drug-induced disorder treatment. This was a recent publication of us, where we present 10 cases where clinical pharmacological interventions helped our patient. And this is again another review on clinical pharmacological reconciliation review and feedback. This terminology is actually proposed by my mentor, Professor Shantanu Tripathi, sir. This already we had discussed. Due to lack of time, I am not going in details of these points. Yes, there are certain challenges in this CPRRF. First of all, the number of specialists providing this service is still very less in this country, but we have enough resources. We have many pharmacologists, many clinical pharmacologists now. If we increase the service, we can reach in different parts of the country. Yes, there are a lack of clinical exposures during our pharmacology PG trainings, but current curriculum suggests we need to have more clinical training. The awareness levels and confidences of other clinical colleagues, yes, that is a question mark again. But if we follow the mantra of no name, no shame, no blame, then we can address this, and more awareness programs can address this type of challenges. And of course, we need willingness of the administrators. So in nutshell, the concluding slides, the clinical pharmacologist should play a significant role in promoting prudent use of medicines. At least the clinical pharmacology principles can be used. It is not only the clinical pharmacologist, the pharmacologist can use the clinical pharmacological principles. The medicine people, they can use these clinical pharmacological principles to promote prudent use of medicines. And we all acknowledge that WHO long back emphasized the need to integrating clinical pharmacology with health service system. But it seems we still have a long way to go to make this a reality. And application of these principles in different subspecialty domains is need of our policymakers should design and execute a novel strategies to speed up this process. This time I missed to be present in this holy place of Rishikesh and Haridwar. In fact, we, with my mentor, Professor Shantanu Tripathi, and my father, Devdas Shamasdar, you can see in this picture, we enjoyed a lot during the conference held in Rishikesh AIIMS on meditation. But what I had learned from that meditation conference is that if we convert I to we, then we can convert illness to wellness. And here also, the clinical pharmacological reconciliation review and feedback need a team-based approach. Here, no scope of some I. We need to become we. With that, again, I thanks the organizer for providing me this opportunity. Thank you. If you have any comments or questions, we can address that.
Thank you, Shambhu. That was a fascinating presentation. Thanks a lot for that. And we enjoyed your pictures as well. I am opening this to questions from the audience. If there are any, just wait a moment and we will relay.
But I have a query. Sir, what are the major strategy used in clinical pharmacological reconsultation, review and feedback in ensuring patient safety?
Yeah, thank you, sir, for the question. So as the terminology itself, there is three parts. One is reconciliation. So first of all, we should reconcile the prescription. We need to check the prescription first. We need to take a good medication history. We need to know what are the problems for the patient. Any problems linked with the drug that had been consumed by the patient, or the drug effect is not optimized to the desired level. After this reconciling, we should have a proper review. So when we are talking about as a whole CPRRF principles, CPRRF therapy, it is just not like what we do in day-to-day clinics. So yes, we can give a patient a reconcile advice first, but also we need to tell our patient that you will get a feedback later. So in between that, we should have a proper review. If we have some doubts, we should go by the literature, whatever present in the net. We should talk with our peers if we have any confusion. And finally, after gathering everything, in the second visit, second counseling, we should provide a proper feedback. So this CPRRF has three parts. Number one, the reconciliation part, which we can provide patient immediately. Then number two is the review part. That means we need to do the review background work. And then finally, the feedback that should be provided to the patient after accumulating all necessary informations.
Thank you, sir. It was very helpful for us. Thank you.
Thank you, sir.
Do we have any more questions from the audience? Okay, if no, then we'll proceed. Thank you, Shambhu sir, for an informative and captivating session. May I now request our chairperson, Dr. Jay Prakash, Principal Scientific Officer, PVPI, to kindly felicitate Professor Ratinder Jaj with a memento.
And there is no substitute for the experience they have gained. So reconciliation, reduction of the medication errors, that will come once we are going through this process. And as we learn more and more, that the things will be refined. And the third element, then only we will be able to reduce the number of drugs and will put the patient at more benefit than the risk. So thank you, both the speakers.
Thank you, sir. Thank you.
Also, I express my heartfelt gratitude to Dr. Shambhu Samishkar. Now I call upon Professor Syed Ziaur Rahman sir to felicitate chairpersons of this session.
And how are the remote speakers going to be facilitated?
Sir,
I thank our speakers and chairpersons for sharing their knowledge and expertise. Now I invite you all for lunch, which is served at level 2 of this auditorium. We meet back at 2:30 p.m. for the next session. Kindly come back to the auditorium by 2:30 p.m.